this weekend and the next weekend. So we'll try and cover at least 3 topics today. And I'm starting off with general physiology today. Now, general physiology, as far as your All India PG exam is concerned, a lot of focus on general physiology by the national board. That means your All India PG exam as well as your DNB exams. A lot of questions have started coming from this first chapter. So we need to do this chapter in a little bit of detail, which I will be doing today. We will also try and cover up neuron and skeletal muscle today. So let's see how far we go and how far we are successful in completing these 3 topics. Now, what I would like to suggest is, just to make sure that our pace is maintained, see, I will be giving you a break every 2 hours, right? So I suggest that whatever you don't understand, please make a note of it. And in the break, type out your queries so that when I come back after the break, I'll take on those queries. We'll spend the first 15 minutes of the next session on sorting out your doubts, right? Because otherwise, when you are typing here, it distracts me, it slows our pace, and we will take too much of time, right? So I suggest that. So let me allow me to continue for 2 hours, right? I will try and be as clear and as lucid as possible, but you will have to, you'll also have to cooperate with me in the sense that I want you to write out your queries during the break, and I will solve them, whatever doubts that you have. Just make a note of it and type them out during the break so that when I come back from the break, I can solve all your queries. I think that's fair enough, isn't it? Okay, so let's start off with our first chapter, and this first chapter is general physiology. Take note. Take note. Okay. Okay, so general physiology, our first topic for today. And in general physiology, this will cover a lot of your, I'll also be covering a lot of your biophysics part. You know that All India is expecting you to know some amount of biophysics, right? So that also will be covered in this chapter itself. A lot of it will be covered here. And then as we go along, we'll be covering biophysics also. Now, as far as general physiology is concerned, the first concept that I'm going to take up with you is the concept of total body water. Now, total body water, if I express it in terms of percentage of body weight, in percentage of body weight, this is 60% of the body weight. 60% of the body weight is the total body water. Now, if there is a man, 70 kg man, how much is going to be the total body water? So it becomes 60% of 70 kgs. That means it is 42 kgs or 42 liters. One and the same thing? Because when we talk of water, you know that 1 kg of water is equal to 1 liter of water. So this is your total body water, 60% of body weight. Now this total body water is divided into 2 main compartments. 2/3 of total body water is in the ICF and 1/3 is in the ECF. 2/3 in the ICF, 1/3 in the ECF. Now, there was a recent question in the recent DNB exam. 66% of the total body water is in which compartment? That is, 2/3 is also 66%. That means in total body water, 66% of that, or 2/3 of the total body water, is in the ICF, and 1/3 or 33% of the total body water is in the ECF. Clear? Now this ECF, the way to remember this distribution of total body water, ICF and ECF, we have something known as the 60-40-20 rule. And what is the 60-40-20 rule? 60% of the body weight is total body water. 40% of the body weight is ICF. 20% of the body weight is ECF. Have you got it? 60-40-20 rule. 2/3 of the total body water is in the ICF, or 40% of the body weight. 1/3 of the total body water is in the ECF, or 20% of the body weight. So that's how you remember this 60-40-20 rule, right? Now the ECF, like I said, this is 40% of body weight, this is 20% of body weight. ECF is further subdivided into plasma, which is 5% of body weight, and interstitial fluid, which is 15% of body weight. Plasma 5% and interstitial fluid 15% of the body weight, right? Now there is a third component of ECF which cannot be traditionally measured, in the sense that by conventional methods we cannot measure this third component. So when we measure ECF, we can only measure plasma and the interstitial fluid, but for theoretical purposes, we must know there is a third component of ECF, and this is what is known as transcellular fluids. Transcellular fluids. Now, what are these transcellular fluids? These are fluids which are contained in their own space. जैसे pleural fluid, right? जैसे pericardial fluid, जैसे joint fluid, जैसे aqueous humor, right? All of these are part of ECF but contained in their own spaces, right? So when we are measuring ECF, we cannot measure these transcellular fluids, but we must know that there is a third component of ECF which is called transcellular fluids, and these are less than 1.5% of the body weight, or less than 1 kg in a 70 kg man. Less than 1 kg in a 70 kg man. So less than 1.5% of body weight, or less than 1 kg in a 70 kg man. Are we clear with that? Right? So this is your distribution of the total body water. So we can just revise it once again. 60% of body weight is the total body water. 2/3 of the total body water is in the ICF, or 40% of body weight. 1/3 of the total body water is in the ECF, which is 20% of body weight. This is further subdivided into two compartments: plasma 5%, interstitial fluid 15%, and the transcellular fluids, which are, these are your transcellular fluids, which are less than 1.5% of body weight, or less than 1 kg in a 70 kg man, right? So this is as far as your distribution of total body water is concerned, right? Next, let's see. Next, let's see how do we measure these different body fluid compartments. Measurement of the body fluid compartments, right? Now, this is some body fluid compartment whose volume is not known. Body fluid compartment जिसका volume determine करना है. Volume is not known. Right? So it's a diagrammatic representation. It could be ECF, it could be plasma, whatever, right? Some body fluid compartment, jiska volume is not known. So what do? We add Q, and what is Q? Q is known quantity of a suitable dye or indicator. Suitable dye or indicator is added to this unknown volume. Known quantity of a suitable dye or indicator is added to this unknown volume. So what happens is, now we wait for this dye to distribute evenly and thoroughly. To this unknown volume, I have added Q. Q is a known quantity of a suitable dye or indicator which is added to this unknown volume, and we have to wait for this dye to be distributed evenly and thoroughly, right? And once the dye is distributed evenly and thoroughly, we now withdraw a sample. We withdraw a sample, and we see the concentration of dye in that sample, and let that be C. Concentration of dye is seen in that sample, and let that be C. Volume. This is some body fluid compartment. We added Q, which is a known quantity of a suitable dye. We allow the dye to mix evenly in this body fluid compartment. Then we withdraw a sample and we see the concentration of dye in that sample, and let that be C. So the formula that we use is V is equal to Q minus E over C. And what is Q? Q is the quantity of dye injected. E is the amount of dye. What is E? E is the amount of dye metabolized or excreted. Metabolized or excreted during the procedure, right? The amount of dye metabolized or excreted. Metabolized or excreted during the procedure, right? This is the amount of dye metabolized or excreted during the procedure. And C, of course, you know, C is the concentration of dye in a sample withdrawn after mixing has taken place. See, preferably E should be 0. Preferably, the amount of the dye metabolized or excreted should be 0, or E should be known. One of the two things, right? So this is your formula. V is equal to Q minus E over C, right? If we've understood the formula, then we can take on the first question. Let's take this. Now, I want to determine ECF volume, right? I want to determine the ECF volume. And to determine ECF volume, I am going to use 150 milligrams of sucrose. I'm going to use 150 milligrams of sucrose. Sucrose is an indicator, or a dye for that matter, which is used to determine ECF volume, right? So Q is equal to 150 milligrams of sucrose. Now, what is the procedure? Let's try and understand this. Now, I inject 150 milligrams of sucrose IV, right? Sucrose is a indicator which will distribute itself in the plasma, and it will go via the tissue capillaries into the interstitial fluid, right? I have injected 150 milligrams of sucrose IV. This distributes itself in the plasma and then goes via the tissue capillaries into the interstitial spaces. Okay? Now we have to wait till the dye distributes evenly in the plasma in the interstitial space. That means basically, see, I'm using sucrose to measure ECF. So I must wait for sucrose to be distributed evenly in both these compartments, plasma as well as interstitial fluid. I have to wait till an equilibrium is achieved. Equilibrium money? Concentration in the plasma and interstitial fluid is the same, right? Now after equilibration, I withdraw a plasma sample, right? And we see that the plasma sucrose is 0.01 milligram per ml. Please understand, this is after equilibration, right? This is after equilibration, the plasma sucrose, right? And also 10 milligrams of sucrose is metabolized and excreted during the procedure, or E is equal to 10. The question says, what is the volume of the sucrose space? Now, what do I mean by sucrose space, Mani? Sucrose space means what is the volume of the compartments in which sucrose has been distributed. And we know that sucrose will enter into the plasma as well as the interstitial fluid. So volume of sucrose space, is it 10,000 ml? Is it 12,000 ml? Is it 14,000 ml? Or is it 16,000 ml? A, B, C and D, right? Now here the formula is V is equal to Q minus E over C. Q is 150 milligrams, E is 10, C is 0.01. If you solve this problem, if you solve this math, this little equation, you will get the answer as 14,000 ml. Are we clear? 14,000 ml. So not very difficult, right? So the formula that we have to remember is V is equal to Q minus E over C. Okay? Now this is as far as your distribution of total body water, and what is how do I measure these body fluid compartments. Now the name of this technique, this measurement of body fluid compartment, what is the name of this technique? This technique is known as the dye dilution technique. Dye dilution technique, or sometimes also known as the principle of volume distribution. Dye dilution technique or the principle of volume distribution. This is the name of this method. V is equal to Q minus E over C. Chaliye, let's go. Let's take it forward from here, and that is right. Now let's see this. After this, let's have a look at what are the indicators used for different body fluid compartments. So let's see this. For total body water, the indicator that we use is deuterium oxide or heavy water. Deuterium oxide or heavy water, tritium oxide, and aminopyrene. Deuterium oxide, tritium oxide, or aminopyrene, right? And the question which has been asked is, out of these three, which is the most frequently used? This is the most frequently used for determination of the total body water. All India PG question. Most frequently used for the determination of total body water is D2O. Most frequently used. Clear? Next, for ECF, I just told you, gave you one question. So that is sucrose, mannitol, and inulin. Sucrose, mannitol, and inulin. And out of these, most accurate is inulin. This has also been asked as a question. Out of the three, which is the one which is most accurate? Most accurate is inulin. Now for ICF, remember, it begins with an I. This is an indirect measurement. Indirect measurement. Indirect measurement money. This is total body water minus the total body water minus the ECF, right? So this is for ICF, that is total body water minus the ECF. Money. Now if I ask you a question, what is the ideal? Which are two? I will need two dyes for the measurement of ICF. It's an indirect measurement. I need two dyes. So which is the best combination? Have you understood? Now my best combination, which has also been asked as a question, you were given 4 different combinations and you had to pick up the best one. This now becomes D2O and inulin. D2O and inulin. So this has been asked as a question, which is the best combination of dyes that we need for the measurement of from the measurement of the ICF. Like I said, it is an indirect measurement, right? Now, next is, how do I measure plasma volume? Let's see, how do I measure plasma volume? What is the indicator used for measurement of plasma volume? Please remember, ECF is equal to plasma plus interstitial fluid. See, when I want to do an ECF measurement, I used sucrose. Now, sucrose was injected IV. It distributes itself in the plasma and into the interstitial fluid, right? And remember I told you we have to wait for equilibration. That means the concentration in the plasma and the interstitial fluid is the same. Then if I withdraw a plasma sample, it will be the same as an ECF sample. Have you understood? Please understand the key word here is you have to wait for the dye to mix evenly in that body fluid compartment, right? So you have to wait till equilibrium is achieved. Yes, but to measure plasma, the dye that I need has to stay within the intravascular compartment. Have you understood? It has to stay within the intravascular compartment. For ECF measurement, I need a dye which will distribute itself in the plasma and in the interstitial fluid, right? Because remember, ECF consists of plasma and interstitial fluid. But if I want to measure the plasma volume, then the dye should stay within the vascular compartment, right? And the dye which manages to stay within the vascular compartment is Evans blue. Evans blue, this is T1824. And you can also use radioactive iodine labeled albumin. Radioactive iodine labeled albumin. So this is also used for the measurement of plasma. For interstitial fluid, again it begins with an I. This is also an indirect measurement. It is an indirect measurement, right? That means now this becomes ECF minus the plasma. ECF minus the plasma, right? So this is as far as what are the dyes required for the different body fluid compartments. What are the different dyes required for different body fluid compartments. Now let's take an Ames question here. And let's see fastest finger first, right? Let's see which center comes up with the right answer. Yes? Now this is an Ames question which says, there is a dye XYZ which I am measuring, which I'm using to measure plasma volume, right? I have a dye, some dye XYZ, and it is being used to measure plasma volume, right? Now this is replaced by another dye ABC. But what is the problem with this dye? That this dye, it diffuses out of tissue capillaries. This dye diffuses out of tissue capillaries. This dye diffuses out of tissue capillaries. So what will happen to my plasma volume measurement? A, will it be the same as with XYZ? B, will it become falsely high? Or will it become falsely low? Right, so Vishakhapatnam's got it, right? Pune, you are wrong. Now, falsely high. See, why falsely high? Remember, V is equal to Q minus E over C. Now, E has not been mentioned here. So, I take it for granted that E is 0, right? Now, what happens is, this dye has diffused out of the tissue capillaries. This is a tissue capillary here. We were waiting for the dye to mix evenly and thoroughly. And during the mixing, this dye has diffused out of the tissue capillaries. Yes, when this dye diffuses out of tissue capillaries, what will happen to C, the concentration of the dye? This will now decrease. If the denominator decreases, what will happen to my quotient? My quotient automatically increases. So what will happen? This becomes a falsely high measurement. Please understand, to measure the plasma volume, I must have a dye which stays within the vascular compartment. Now this is, like I said, XYZ. We used XYZ. We got some value of the plasma volume. We replaced it by another dye, ABC, but this dye diffuses out of tissue capillaries. So while we were waiting for the dye to mix evenly, it diffuses out of tissue capillaries. And once it diffuses out of tissue capillaries, what will happen to our concentration of the dye? This now decreases. ठीक है ना? So if the denominator decreases, what will happen to the volume? Volume increases. That means this becomes a falsely high measurement. Falsely high measurement. Right? So this is as far as our distribution of total body water and which are the dyes required for different body fluid compartments. Right? चलिए, उसके बाद let's have a look at what are the factors affecting the total body water. Factors affecting total body water. Factors affecting total body water क्या है? Number one is age. Now, as age increases, total body water decreases. As age increases, total body water decreases. That is why the elderly become more susceptible to dehydration. They are more susceptible to dehydration. Why so? Because the elderly as it is have a low total body water. So they become susceptible to dehydration. As age increases, total body water decreases. Second factor which affects total body water is the amount of fat. More the amount of fat, less the total body water. More the amount of fat, less the total body water. That means, question, All India PG question, obese person will have a total body water that is same as that of a normal person, less than that of a normal person, or more than that of a normal person. So obviously this becomes less than that of a normal person. Right? Obese person will have a total body water which is less than that of a normal person. Okay? Now if I look at water content of lean body tissue. Water content of lean body tissue. Now what is lean body tissue? Lean body tissue is body tissue minus the fat. This is water content of lean body tissue. This is 71 to 72% or 71 to 72 ml per 100 gram of lean body tissue. 71 to 72 ml per 100 gram of lean body tissue. This is your the water content of lean body tissue, 71 to 72%. Right? So that means what changes this? What changes this is the amount of fat which is present. More the amount of fat, less the total body water. In fact, if you look at males and females, males have a total body water which is 60% of body weight, and females have a total body water which is 50% of body weight. Obvious reason, because women have a higher content of fat. Right? So this is as far as your water content. So water content of lean body tissue, by the way, this has been asked as an All India PG question. How much is the water content of lean body tissue? This is 71 to 72%. That means what decreases the amount of water is the presence of fat. Males have a total body water which is 60% of body weight. Females have a total body water which is 50% of body weight. Right? Now there's a recent DNB question which says that males and females will have equal amounts of body water in which age group? Have you understood? Males and females have total body water which is equal amount of total body water in which age group? So it has to be the pre-pubertal. Have you got my point? Pre-pubertal, before puberty. Absolutely right, Karamsad. It has to be before puberty, isn't it? Because after that, the distribution of body fat. Right? So there will be a changes in the amount of body water in males and females. So it's in the pre-pubertal age group that you will have the same amount, equal amounts of total body water. Clear? Now this is as far as your total body water is concerned. So we've done the distribution of total body water, we've done measurement, we've seen what are the dyes used, what are the factors affecting the total body water. Next, let's go on to some very basic principles of physiology. And herein I will be talking about what are the concepts of mole, osmole, osmolarity, osmolality, because these are terms which really confuse us, right? So let's try and spend some time over here and make everything absolutely clear. Now, the first concept that I'm going to take up with you is the concept of a mole. Now, what is mole? Mole is the gram molecular weight. Gram molecular weight. It is the molecular weight of a substance expressed in grams. It is the gram molecular weight of a substance, right? For example, oxygen has an atomic weight of 16, right? Molecular weight of 32. So 32 grams of oxygen is equal to 1 mole of oxygen. Mani, if I want to know how many grams make up 1 mole, whatever is the molecular weight of the substance, add a gram to it, that becomes the mole. So like I told you, atomic weight of oxygen is 16. So 32 is the molecular weight. So 32 grams of oxygen is equal to 1 mole of oxygen. 32 grams of oxygen is equal to 1 mole of oxygen, right? Now, on the same basis, albumin. Albumin has a molecular weight of 69,000. So 69,000 grams of albumin is equal to 1 mole of albumin. Have you understood? And we've also done this in school, if you remember, that 1 mole of any substance will have the same number of molecules, which was Avogadro's number. You remember that? This was 6.023 into 10 raised to the power of 23. Right? That was the concept of a mole. Gram molecular weight of a substance. Right? And what is a millimole? Millimole is 1,000th of a mole. 1,000th of a mole is a millimole. Right? Now comes, what do you understand by osmole? How are osmole and mole related? Now, 1 osmole of a substance is equal to 1 mole divided by number of freely moving particles. Number of freely moving particles liberated in solution. Number of freely moving particles liberated in solution. One osmole is 1 mole divided by number of freely moving particles liberated in solution. One osmole is 1 mole divided by number, like for instance, when we dissolve sodium chloride in water, right? When we dissolve sodium chloride in water, it splits into 1 sodium and 1 chloride. In other words, I can say that 1 osmole of sodium chloride is equal to 1 mole of sodium chloride divided by 2. It splits into 2 particles. So it's 1 osmole is equal to 1 mole divided by 2, right? Now, if I ask you, 1 mole of sodium chloride is equal to how many osmoles? Now I've asked you the reverse. Now I'm asking you, 1 mole of sodium chloride is equal to how many osmoles? So what do? I must cross multiply. So what do I get? That this will be equal to 1 mole of sodium chloride is equal to 2 osmoles, right? Similarly, 1 mole of potassium chloride will be equal to how many osmoles? 1 mole of potassium chloride? Yes, 2 osmoles. Because potassium chloride splits into 2 particles. Similarly, 1 mole of calcium chloride is equal to how many osmoles? 3. It splits into 3 particles. 1 calcium, 2 chloride. 1 mole of C6H12O6 is equal to how many osmoles? 1. Yes, Meerut. This is 1 because what is C6H12O6? This is, of course, glucose. Glucose is an organic compound which does not split, right? So this is 1 osmole. So 1 mole of glucose is equal to 1 osmole of glucose. And similarly, 1 mole of albumin is equal to 1 osmole of albumin. Right? So this is as far as a general concepts of mole and osmole is concerned. And of course, milliosmole will be the same thing. Milliosmole is also 1,000th of an osmole. So 1 milliosmole is 1,000th of an osmole. Right? So this is as far as our concept of mole and osmole is concerned. Now, what am I interested in as a student of physiology is what do we understand by osmolarity and osmolality. So let's discuss that. Now, osmolarity and osmolality. Osmolarity and osmolality. Now, osmolarity, this is the number of osmoles of solute per liter. See, osmolarity has got an L and R. There is an L and R in osmolarity. There is an L and R over here. So this is number of osmoles of solute per liter of solution. Per liter of solution. Whereas osmolality, this is number of osmoles of solute, but this is per kg. This is per kg of the solvent. There is a very subtle difference between the two. One is per liter of solution, the other is per kg of the solvent. Per liter of solution and per kg of solvent, right? Now, out of these two, which is a better term? The better term is osmolality. Why? Because osmolarity is affected by temperature, and this is affected by the presence of other solutes in solution. Presence of other solutes in solution, right? This is affected by temperature and by the presence of other solutes in solution, right? So this is, so what is a better term? Like I said, out of the two, which is a better term is osmolality, not osmolarity. Osmolarity can change depending on the temperature and depending on the presence of other solutes in solution, right? So this is as far as our osmolarity and osmolality is concerned. Now, we've revised our basics, we've revised our school knowledge, and let's go on to now. How is it relevant to us now? And my first question here is, what is normal plasma osmolality? Obviously, I'm going to use the term osmolality because we said it is a better term. So, normal plasma osmolality kitna hai? Is it 260 to 270 milliosmoles per liter? Is it 270 to 280? Is it 280 to 290? Is it 290 to 300 milliosmoles per liter? Right? Now, my best answer here, A, B, C, or D. My best answer here is this one, right? C, 280 to 290 milliosmoles per liter. 280, I hope you can read this as 280. 280 to 290. Now, if I have only one figure to choose, supposing the question says, is it 260, is it 270, is it 280, is it 290? Then what becomes my best answer? Then my best answer becomes 290 milliosmoles. Range, if they ask you a range, it should be 280 to 290. But if I have to choose a single figure, then my answer. Range, Vishakhapatnam, Srinagar, please just take a note of it. Allahabad, please make a note of it. Best range is 280 to 290 milliosmoles per liter. But if I have to choose a single value, if the question says how much is normal plasma osmolality, is it 270, is it 280, is it 290, is it 300? In that case, I will choose 290. But if the range is Ludhiana, just wait for a minute. This is 280 to 290 is the best range, and this should be, if one single figure, 290. Now, like Ludhiana has come up with this doubt, and that is, it should have been, when I'm asking you osmolality, 1 second, Jammu and Vishakhapatnam, let me finish. Now, if I'm asking you osmolality, it should have been milliosmoles per kg. Agreed? This is the doubt which is coming into your mind. Yes, I can see from the questions that have come in, Ludhiana, Jammu, Vishakhapatnam, Meeraj, isn't it? Osmolality, so I should have written milliosmoles per kg, but I've written milliosmoles per liter. Obviously, this can't be wrong because I am the physio ma'am after all, so it can't be wrong. So there must be some other explanation to it. And that is, see, what is the solvent in plasma? Water. So whether I write per kg of water or per liter of water is one and the same thing. But please understand, when I'm talking of osmolality, this per liter refers to the per liter of the solvent, not the solution. Have you understood? If it was osmolarity, it would have been per liter of the solution, which is plasma. But this is, the solvent in plasma is water. Therefore, whether I write per liter of water or per kg of water is one and the same thing. This happens when we've opened our book and we read osmolality and it says so many milliosmoles per liter. Nothing wrong. Just that because the solvent in the plasma is water, therefore I am at liberty to use per liter or per kg. Right? So I hope that sorts out your doubt which crept into your mind. So this is normal plasma osmolality. Okay. Now let's go on to our next question related to osmolality, and that is, what contributes maximum to plasma osmolality? What contributes maximum to plasma osmolality? A, is it sodium and its associated anions? Is it sodium and its associated anions? B, is it potassium? C, is it glucose? D, is it urea? E, is it plasma proteins? Let's see fastest finger first. Okay. So most of you, Karam Sad has said albumin, but the others have said, Vishakhapatnam is also saying proteins, but the rest of you are saying A. And in fact, A is the one which is correct. Sodium and its associated anions, these contribute 270 milliosmoles out of 290. 270 is because of sodium and its associated anions. Right? Now, what do I mean by its associated anions? Associated anions, money? See, sodium is never alone in the plasma. Sodium is associated with an anion. It could be chloride, it could be bicarbonate. Right? So, it's sodium and its associated anions. See, in fact, if somebody asks you that patient's sodium is 140 millimoles per liter or milliequivalents per liter, for sodium, it can be written either way, millimoles or milliequivalents. Now, patient sodium is 140 and you are asked a question, how much is the osmolality? So, what do? You multiply the patient sodium by 2. Why have I multiplied it by 2? Because it is associated with an anion. Anion could be a chloride or a bicarbonate. So, I will multiply it by 2. Have you got my point? This is for a rough idea of plasma osmolality. Multiply the serum sodium levels by 2. Now potassium, I gave you an option of potassium. Now potassium is mainly intracellular. So hardly any contribution to osmolality. Glucose is 5 milliosmoles, but obviously if you have a patient of diabetes, hyperglycemia, this will increase. If this increases, you know plasma osmolality will rise. And what is the most common symptom whenever there is an increase in osmolality? What is the most common symptom when there is increase in osmolality? Thirst. So you know that diabetes, polydipsia is a common feature. Urea contributes 5 milliosmoles. Now, at least one or two of you had answered. Plasma proteins is the answer. Now see this. Plasma proteins, in fact, all the proteins put together, albumin, globulin, prothrombin, fibrinogen, all the clotting factors, all the transport proteins put together, they contribute only 2 milliosmoles to plasma osmolality. Hardly anything, right? So sodium and its associated anions contribute 270, potassium hardly because it's mainly intracellular, glucose, urea, plasma proteins are this, and all the remaining ions which includes potassium, which includes calcium, which includes sulfates, everything else put together will contribute 8 milliosmoles, and if you add up the total, it comes to 290 milliosmoles per liter, right? So this is our contribution of the different factors to osmolality, right? Now after this, now like some of you had said, plasma proteins is the major contributor to osmolality. Now I said it contributes hardly anything, 2 milliosmoles. Now my next question is, why is it that plasma proteins contribute to so little to osmolality? So let's discuss that. Yes, why is it that some of us thought plasma proteins is the answer, but actually in fact it is contributing hardly anything, just about 2 milliosmoles. So let's discuss that. Now proteins, when I ask you how much is normal level of proteins, how much are normal proteins, and the answer is 6 to 8 grams %. Right? That means the normal value of plasma proteins, normal plasma proteins, this is 6 to 8 grams %, means per deciliter per 100 ml or per 100 ml, right? And if I ask you how much is albumin, this is 3.5 to 5 grams per deciliter per 100 ml. That means in 1 liter, I have almost 35 to 50 grams in 1 liter, which is a very large, not very, but fairly large quantity. It's not less, 35 to 50 grams. But now let's try and convert these grams to moles, right? If you remember, I told you at the beginning of this section, I told you that 69,000 grams of albumin is equal to 1 mole of albumin, which is equal to 1 osmole of albumin. We have already discussed this, and I'm sure right? 69,000 grams is equal to 1 mole of albumin, or which is also equal to 1 osmole of albumin. We've discussed this already. So now let's see 50 grams of albumin, which is present in 1 liter of plasma. How many moles is that? This now becomes 1 upon 69,000 into 50. In other words, this becomes 5 divided by 6,900, or 0.00000 and something moles, which is also equal to 0.00000 something osmoles. Mane kya? What do I mean by this? I meant in terms of grams, it was looking like a fairly large quantity. But when I converted these grams to moles, I got a 0.0000 something moles and 0.0000 something osmoles. my point? The moment I converted it into moles, this became a very small quantity because the molecular weights of albumin are very high. And in fact, out of the proteins, albumin has the lowest weight. Globulin is 140,000. Right? 140,000. The fibrinogen is 400,000. So imagine their contribution, their number of moles and osmoles will be in fact even lower. Yes. So this is the reason why their contribution to osmolality is so little is because their molecular weights are very high. Have you got my point? And thank you, Jammu, for giving us a figure, but I know that all of us have got mobiles and calculators, so I know I should be suitably impressed. Okay, I am. All right. Thank you. So have you understood this concept? That is more important. Okay? Okay. So let's try and reinforce what we have learned by doing two questions. And that is the first one. Plasma proteins contribute only 2 milliosmoles to plasma osmolality because A. High molar concentration, high molecular weight. B. Low molar concentration, low molecular weight. C. High molar concentration, low molecular weight. D. Low molar concentration, high molecular weight. Bolo. A, B, C or D? Okay, great. So all of us have got this concept. Yes, this is now a low molar concentration and a high molecular, low molar concentration because of high molecular weight. Right? So this concept is perfectly clear, I think. That's what I can gauge from your responses. And I'll do another question with you now. Now the same question, plasma proteins contribute only 2 milliosmoles to plasma osmolality because A. High concentration. Now it just says concentration. And when it says concentration, it means in terms of how we normally express plasma proteins. And how do we normally express plasma proteins? In terms of grams per deciliter. Have you understood? So this becomes now high concentration, high molecular weight, low concentration, low molecular weight, high concentration, low molecular weight, low concentration, high molecular weight. अब बोलो क्या है? Right? In grams per deciliter, it becomes a fairly high concentration, but in terms of mole, it is a low concentration because their molecular weights are very high. अरे श्रीनगर D कैसे? Concentration, जब सिर्फ concentration mentioned है, that means now it has to be in terms of grams per deciliter. In grams per deciliter तो ज़्यादा था ना? 50 grams per liter या 5 grams per deciliter. Fairly okay, fairly large concentration. जब हमने उसे moles में किया तो it became a low molar concentration because of high molecular weight. Right? See, we've answered this. This was a low molar concentration because of high molecular weight. So in terms of concentration, high. In terms of molar concentration, low because of a high molecular weight. Srinagar, have you understood it? Have you understood this question? Okay. Right? So in terms of grams, fairly high concentration, low concentration in terms of moles because it has a high molecular weight. Right? So this is as far as our osmolality is concerned. Next, let's see. Next, what do you understand by osmotic adaptation? What is osmotic adaptation? Right? Osmotic adaptation. Let's discuss this now. Now, as far as osmotic adaptation is concerned, see, normally the plasma osmolality and the cell's intracellular osmolality will be the same. Right? It has to be the same. Otherwise, what will happen? The cells will either start gaining water or losing water. Supposing the inside osmolality is higher than the outside plasma osmolality, what will happen? The cells will start gaining water. Or if the inside osmolality is lower than the plasma osmolality, then again the cells will start losing water. Have you got my point? So, normally intracellular and outside osmolality has to be the same. That means if it's 290 milliosmoles inside the cells, outside the cells, it is 290 inside the cells. Okay? So this is as far as this is the normal situation. Now we also know that major contributor to osmolality is sodium. So supposing there is increase in serum sodium levels. Increase in serum sodium levels, this will obviously increase the plasma osmolality. Now, if the plasma osmolality starts increasing, this will now start affecting the volume of the cells. And especially, which are the cells which we are most concerned about are the brain cells. Right? So, in this sort of a situation, now the brain cells will osmotically adapt. They will osmotically adapt. Right? Osmotically adapt money. Now they will try to ensure that their inside osmolality is equal to the outside osmolality. So how does that happen? Have you understood what I'm trying to say? Osmotic adaptation. Osmotic adaptation is whenever there is increase or decrease in serum sodium levels. Supposing there is a decrease in serum sodium levels, now the plasma osmolality will decrease. Intracellular osmolality is at 290, outside has become lower. So what will happen now? The cells will start gaining water. Have you got my point? So in these two situations, our brain cells will show the phenomena of osmotic adaptation. So let's see this. Now, when do I see osmotic adaptation? Let's take the first example. Supposing there is a chronic hypernatremia. Chronic hypernatremia. Chronic hypernatremia means now there is an increase in serum sodium levels, and this increase in sodium is more than 24 hours. Increase in serum sodium levels is more than 24 hours. This is a chronic hypernatremia. Right? More than 24 hours. Right? Serum sodium levels have been elevated for more than 24 hours. Right? In this situation, the brain cells will show the phenomena of osmotic adaptation. Please understand, adaptation takes time. So you will not see this whenever there is acute change in serum sodium levels. It has to be for more than 24 hours to produce osmotic adaptation. Now, how does this osmotic adaptation occur? Number one, there is an increased intracellular synthesis of osmolytes. Increased intracellular synthesis of osmolytes, and the osmolytes are betaine, inositol and glutamine. बीच बीच में ना मिस कर रहा था ये, अभी उसको टाइप किया है. There is an increased intracellular synthesis of osmolytes, betaine, inositol and glutamine. Right? All of these, Now, whenever there is increased intracellular synthesis of these osmolytes, they will increase the intracellular osmolality. Have you understood? Outside osmolality has increased because of increase in serum sodium levels. Now, brain cells increase the inside osmolality so that there is no change in volume. Right? And number two, in this situation, there is import of sodium. Small amounts of sodium are imported from outside to inside the cell. Right? So this is your import of sodium. This is how the intracellular osmolality now increases to match the increase in osmolality outside. So this is seen in situations of chronic hypernatremia. Right? Now let's see what happens if there is a chronic hyponatremia. Let's see if it has to be chronic hyponatremia. That is now decrease in serum sodium levels has to be for more than 24 hours. Please understand, less than 24 hours, you need at least 24 hours for the brain cells to osmotically adapt. Now what will happen? Now brain cells will osmotically adapt. How? Now there is a decreased synthesis of osmolytes. Decreased synthesis of osmolytes, and osmolytes such as betaine, inositol and glutamine. Right? And number two, now there is some amount of export of potassium. Small amounts of potassium are sent from inside to outside the cell. Right? So this is chronic hyponatremia and osmotic adaptation. See, very important point, clinical point which has come out of this is, see, whenever you have a patient of elevated serum sodium levels or a decrease in serum sodium levels, there is no need to manage this patient aggressively. And why? See, if you have a patient of elevated serum sodium, his brain cells have already osmotic, especially if it's chronic hypernatremia, more than 24 hours. His serum sodium levels have been elevated for more than 24 hours. His brain cells have already osmotically adapted. Now you decide, ki nahi, I must bring down the serum sodium levels, let me give him dilute saline. Your aggressive management. Now what happens is you've lowered the plasma osmolality, but inside osmolality is higher. So now what will happen? Now instead of actually treating the patient, you have created problems for him, because now the water will move from the plasma into the cells. See the other thing, supposing there is chronic hyponatremia. Plasma osmolality has decreased. Brain cells will lower the plasma osmolality to match this. By those two processes I told you, there is number one, decreased synthesis of osmolytes, and number two, export of potassium. Now you decide, no, I must increase his serum sodium level, so you give him concentrated saline. Right? Now what will happen? Your plasma osmolality has increased. Now this will now cause the inside osmolality is lower than the outside osmolality, and now the cells will start losing water. So instead of actually managing your patient, you have created problems for him. Right? So there is no need to manage chronic hypo or hypernatremia aggressively. So this is what I wanted to tell you about the serum sodium levels. Right? Chali. After this, so this was osmotic adaptation. The next thing which I'm going to discuss with you is what is osmotic pressure. Next point here is osmotic pressure. Now, osmolality we have discussed in a lot of detail. Next, let's see what is the osmotic pressure. Now, as far as osmotic pressure is concerned, now osmotic pressure is 1 milliosmol of a solute will exert an osmotic pressure of 19.3 millimeters of mercury. 1 milliosmol of a solute 1 milliosmol of a solute is equal to 19.3 millimeters of mercury, right? Now, what is osmotic pressure? Let's see this. Now, this is something which we did in school, and if you remember, there was a U-shaped tube. There is a semi-permeable membrane here, yes, and it separates two solutions. One is a dilute solution. There is a dilute solution on one side, and there is a concentrated solution on the other side. Right? There is a concentrated solution on the other side. Now, what will happen is water will now flow. There will be movement of water from the dilute to the concentrated solution. Dilute to the concentrated solution. Now, what is osmotic pressure of a solution is? Osmotic pressure is the pressure which is exerted to stop the osmosis. Is called the osmotic pressure of a solution. We've done this in school, right? The pressure which is exerted to stop the osmosis is termed as the osmotic pressure of the solution, right? Now, like I said, 1 milliosmoles of a solute exerts an osmotic pressure of 19.3 millimeters of mercury, or 1 osmole of a solute exerts a pressure of 19,300 millimeters of mercury, right? Now, it can also be written in terms of 22.4 atmospheres. 1 osmole of a solute exerts an osmotic pressure of 19,300 or 22.4 atmospheres pressure. So, Mane, if I ask you a question, what is the normal osmotic pressure of plasma? Osmotic pressure of plasma kitna hoga? Now, is it 6,500 millimeters of mercury? Is it 5,500? Is it 4,500? Is it 3,500 millimeters of mercury? A, B, C, ya D? Right. 5,500, approximately 5,500 millimeters of mercury. This is the osmotic pressure of plasma, and this is 290 multiplied by 12.3. 12.3 karamzad nahi, 19.3, right? So this is your 290 multiplied by 19.3. So approximately 5,500, right? So 5,500 millimeters of mercury. This is the osmotic pressure of plasma, right? Now, then you have something known as, what is the colloid osmotic pressure? Colloid osmotic pressure, sometimes also called the oncotic pressure. Colloid osmotic pressure or the oncotic pressure. Now, this is very important because this is one of the forces which is responsible for tissue fluid formation. So, colloid osmotic pressure or the oncotic pressure. Now, this is the pressure which is exerted by the proteins, right? And we've discussed already that the number of milliosmoles of proteins is 2. Maximum is about 2 milliosmoles. Now, colloid osmotic pressure is not, ideally it should be 2 into 19.3, but the actual value is about 25 to 28 millimeters of mercury. This is about 25 to 28 millimeters of mercury. Yes? So, Meerut and Agartala, both of you are correct, right? So, 25 to 28. This is the normal osmotic pressure or the colloid osmotic pressure. This is due to the proteins. Like I said, ideally, if plasma is an ideal solution, you will talk in terms of 19.3, 2 into 19.3. That gives you a value of something like 38. But the actual figure is between 25 to 28 millimeters of mercury. This is the colloid osmotic pressure of plasma. Now, my next question comes, which protein? Now, this is very important. Let's see if you can answer this. Which protein contributes the maximum to the oncotic pressure? Which protein contributes the maximum to oncotic pressure? Is it albumin? Is it globulin? Is it prothrombin? Or is it fibrinogen? So albumin is your answer. Yes, all of you are correct. This is albumin. And the question arises now, why albumin? Why albumin? Is it because of high concentration, high molecular weight? Is it because of a low concentration, low molecular weight, high concentration, low molecular weight, or low concentration, high molecular weight? Bolo. Not A. What is, no, don't get this concept wrong. See, why albumin? Why is albumin contributing maximum to colloid osmotic pressure is? Because number one, it has a high concentration. Out of all the proteins, this is 5 grams. The others, globulins, are much lower than that. 1.7:1 is the ratio. Prothrombin and fibrinogen are even lower, point something, right? So this is your albumin has got the highest concentration. But out of the proteins, it has the lowest molecular weight. So number of milliosmoles of albumin will be the most out of all the proteins. Highest concentration but lowest molecular weight. Albumin has a molecular weight of 69,000, globulin is 140,000, fibrinogen is 400,000, the others are even larger. So इसका मतलब number of milliosmoles किसके ज़्यादा हुए? Albumin के. ज़्यादा concentration, कम molecular weight out of the proteins. Have you got my point? Right? So the ones who've got C as the answer gets it correct. High concentration but a low molecular weight. Please understand. So Hyderabad, Meerut, Kota's got it wrong. Srinagar's got it right. Karamsad, suno na. High concentration but a low molecular weight. Yes, Bilaspur has got C. But what about the others? Meerut, Ludhiana, Hyderabad, what happened? See, look at this. Question is why out for the osmotic pressure now. I'm not talking about osmolality. See, the osmolality, a major contributor was sodium, least contribution was plasma proteins. Why we said? Because fairly high concentration in terms of grams, low molar concentration because of high molecular weights. That was all right. Now we are talking in terms of colloid osmotic pressure. Not to osmotic pressure of plasma. Osmotic pressure of plasma, main contributor will be sodium. Right? Lekin the contribution to colloid osmotic pressure is because of the proteins. And out of the proteins, I asked you which protein contributes maximum to oncotic pressure. Your answer is albumin. And why albumin? Because it has a high concentration and low molecular weight. Low molecular weight in the terms of out of these 4 proteins. 69,000, globulin 140,000, prothrombin is, fibrinogen is 400,000. The others I don't remember. Right? So this is your oncotic pressure. Colloid osmotic pressure or the oncotic pressure, maximum contribution, albumin. Why albumin? Highest concentration, lowest molecular weight out of the proteins. Osmotic pressure, we lost connection. Chalo. The next thing which I'm going to talk to you about is the cell membrane. Cell membrane. Ludhiana, what am I trying to tell you? I said the colloid osmotic pressure is only because of proteins, right? Proteins are the only ones which are in a colloidal solution. And we said how much is the osmolality of proteins? Just 2 milliosmoles. Okay. So if I want to know the osmotic pressure of the due to proteins, I will multiply 2 into 19.3. That gives me a value of about 38 millimeters of mercury, but that's not true. It's about the actual value of colloid osmotic pressure is 25 to 28 millimeters of mercury, right? So now next point I asked you, that means colloid osmotic pressure is only because of the osmotic pressure exerted by the proteins. Okay. Now the next thing which I said was which protein contributes maximum to colloid osmotic pressure, and the answer was albumin. Why albumin? Because out of the proteins, it has the maximum concentration. It's 3.5 to 5 grams per deciliter. It has the lowest molecular weight. Therefore, its number of millimoles and milliosmoles will be the maximum out of the proteins. That is why we said, why albumin? Because albumin has a highest concentration and we said the lowest molecular weight out of the proteins. Now, what is this conversation which is happening on the side? Yes, roughly equal to 5,500, right? Mumbai, you're right. It should be 5,500 roughly, because please remember, plasma is not an ideal solution, right? So approximately equal to 5,000. The closest figure is 5,500. Okay? So Jammu, I hope that solves your question. Okay, so now let's have a look at cell membrane. Now cell membrane is a lipid. There is a lipid bilayer, plus there is the presence of proteins. Two major constituents. There is lipid bilayer and the presence of proteins. Now, lipid bilayer and proteins. Now, we said proteins, the typical, there is a fluid mosaic model. Fluid mosaic model, right? What is fluid mosaic model? Fluid mosaic model means it's like that chip scuff flooring. Yes, it's the chip scuff flooring, right? Jammu, we can take up your doubts. Like I told you, the first 15 minutes of the next session, I'll devote it to doubts of this session. So just type it out in the break, and I will take that on again. Okay. Now this is fluid mosaic model. Now when I say cell membrane has got a lipid bilayer and it has the presence of proteins. Now fluid mosaic model mane chips ka flooring. So it's the lipid bilayer or beach mein there is proteins which are present, and these proteins have a number of functions. And these functions are, number one, these can act as receptors. These can act as antigens. These can act like channel proteins. These can act as transport proteins. They can act as enzymes. They can act as structural proteins. Right? So these are your different proteins. What are their functions? Now, the first question here comes in. In terms of dry weight of the cell, which is maximum? Is it lipids or is it proteins? My first question. In terms of dry weight, what is maximum? Maximum is in fact proteins. Proteins are approximately 52% of the total weight of the cell membrane. So this is 52%. Now there's another question which I'm going to ask you. What is the lipid protein ratio? Lipid protein ratio in the cell membrane. Is it 1:1? Is it 1:1? Is it 1:2? Is it 1:3 or 1:4? Lipid protein ratio in the cell membrane will be 1:1. Isn't it? It can't be 1:2 because 1:2 mane now proteins are double the amount of lipids. Have you understood my point? Proteins are in fact almost equal to the amount of lipids, slightly more, 52%, slightly more. But if in terms of ratio, which is the closest will be 1:1, not 1:2. Meerut, Kolhapur, Ludhiana, Srinagar, have you understood this? Right? It cannot be 1:2. For 1:2, the proteins have to be double the amount of lipids. But because lipids and proteins are almost equal to it, slightly more. So the two questions, I said which is maximum, then your answer becomes proteins. But when I say lipid protein ratio in the cell membrane, it has to be 1:1. So I hope you've understood this little concept. Okay? Next comes when I look at the cell membrane. Now there was a question which had come. This is related to, now the question which has been asked last time as well as in the DNB this time is related to what are the junctions, what are the different types of junctions in the cell membrane. So let's discuss that. Let's see the different types of junctions. Now the junctions between cells, this is junctions between the cells. Now for instance, this is an intestinal epithelial cell, okay? Intestinal, and this is a neighboring intestinal epithelial cell. Okay? Now present between the two cells near the lumen, obviously where you have the brush border is the lumen. So present over here is a special type of junction which is known as a tight junction. Tight junction. Right? Tight junction. This is the lumen here. Towards the luminal side, between the cells, you have the presence of the tight junction. And this tight junction forms what is known as zona occludens. Zona occludens. Right? Zona occludens. Now the proteins which are responsible for tight junctions are, what are the proteins which are responsible for tight junctions? Tight junctions are formed by, tight junctions are formed by occludens, claudins, and junctional adhesion molecules. Also known as JAMs, right? Appropriate. Occludens, claudins, junctional adhesion molecule. Occludens. Occludins. ठीक है? और this forms the zona occludens. Tight junctions form this zona occludens. बेटा मेरे को पेन दूसरा दे. Right? Occludens, claudins, and junctional adhesion molecule. Karamsad, is that okay? Occludens. Right? Occlude, na? ठीक है? So these are your tight junctions. The next set of junctions between the cells are what are known as desmosomes. These are desmosomes, and desmosomes are associated with intermediate filaments. Desmosomes, and these, like I told you, are associated with intermediate filaments. Intermediate filaments, right? So these are desmosomes and intermediate filaments. Now these desmosomes, they form what is known as zona adherens. Zona adherens. So simple question, zona occludens is formed of tight junctions. Zona adherens will be formed of zona adherens, right? Like I said, zona adherens is formed of desmosomes. Now present on the basal side of the cells, over here are the hemidesmosomes. Right? These are hemidesmosomes. And these hemidesmosomes attach the cell to the basal lamina. This is the basement membrane, right? So these hemidesmosomes attach the cell to the basement membrane, right? So these are called hemidesmosomes. Right? So you've got tight junctions which form zona occludens, then you've got desmosomes which form the zona adherens, and then you've got hemidesmosomes which attach the cell to the basement membrane. Right? So these are your different types of junctions which are present. Now also present between the cells are what are known as gap junctions. So let's discuss the next one, and that is gap junction. Gap junction. Now gap junctions are made of proteins known as connexins. Each connexin has got 6 subunits. They have 6 subunits. And these subunits are known as connexins. Each connexin has got 6 subunits which are known as connexins, right? And these 6 connexins, they surround a central pore. They surround a central pore, right? 6 subunits known as connexins which surround a central pore. And what happens basically is that the connexin of one cell is aligned with the connexin of a neighboring cell. They are in one line. So basically they have formed what is known as an electrical synapse. They formed an electrical synapse. This is a question which has been asked in your All India exam last year. Electrical synapses are formed by gap junctions. Right? So this is a gap junction. Gap junction is basically made of these proteins called connexins. Right? So this is an electrical synapse. Electrical synapse means kya? Electrical synapse means now through this synapse there is an easy passage of ions and molecules from one cell to the other. Easy passage of ions and molecules from one cell to the other. Right? Where do we find these gap junctions, which are the tissues where we see the gap junctions? They are found in the retina. Electrical synapses are common in the retina. They are found in the cardiac muscle. Cardiac muscle. Why cardiac muscle? See, cardiac muscle, what is the advantage of gap junctions? Cardiac muscle, the advantage of gap junctions is the heart is a functional syncytium. Heart behaves like one. It is a functional syncytium. Plus, it is also found in the single unit type of smooth muscle. Or single unit type of smooth muscle kya hai? Single unit type of smooth muscle. This is the smooth muscle that you see in the walls of GI tract. Walls of GI tract. Right? Hollow viscera, basically walls of any hollow viscera. You have the single unit type of smooth muscle, and why is it single unit type? Because it has the presence of gap junctions, right? The walls of GI tract, hollow viscera, that means ureter, uterus, urinary bladder, these are single unit type of smooth muscle. They behave like one because they have the presence of gap junctions. See, heart is a functional syncytium. It behaves like one. So these are the tissues where we find these gap junctions, right? Cardiac muscle, yes, you've got the presence of gap junctions now in cardiac muscles, Meeraj. That is why they behave like one. Heart is a functional syncytium. Have you understood? Atria are one functional syncytium, ventricles are another functional syncytium. They contract together. There is a very rapid spread of impulses in the heart. So you have the heart is a functional syncytium. I hope that's okay, Meeraj. Right? So this is your functional and structural both, na? Structural because of the presence of gap junctions, functional because they contract together. It's a functional syncytium. It's a structural as well as a functional syncytium. Right. So also please remember, what do these gap junctions do? They decrease the intercellular distance. The gap junctions decrease the intercellular distance. Normal intercellular distance is 25 nanometers. It decreases to 3 nanometers. So intercellular distance is decreased from a normal of 25 nanometers to 3 nanometers. Your last year's question, you have been asked, what is the normal intercellular distance? This question was asked, and that is 25 nanometers. But wherever the gap junctions are present, it is reduced to 3. See this now? Again, I'll just repeat this. The gap junctions are formed of proteins known as connexin. Each connexin has got 6 subunits, and each of these is known as a connexin. These surround a central pore. The connexin of one cell aligned with the connexin of another cell, so it forms a sort of an electrical synapse. Yes? And this is the question which has been asked. Electrical synapses are formed due to gap junctions. Now, the tissues which have the presence of gap junctions are retina, the cardiac muscle, and the single unit type of smooth muscle. Smooth muscle is of 2 types. There is a single unit type, there is a multi-unit type. Single unit type of smooth muscle is what you find in the walls of the hollow viscera. For example, GI tract, ureter, urinary bladder, etc. And second function of the gap junction is that they decrease the intercellular distance from a normal of 25 nanometers to 3 nanometers. Right? So this is your connexin. There was another question which was asked, and that is, tight junctions are formed by all except. Tight junctions are formed by all except. And this is now easy. Is it occludins? Is it claudins? Or is it connexins? Boliye? Obvious answer becomes connexins, because connexins form gap junctions, not the tight junctions. So tight junctions are formed by all except. These form the tight junctions. Connexin form the gap junctions. Right? So this is last year's question which was asked. Right. So this is as far as your cell membrane, at least the structure and the junctions between cell membrane is concerned. Next, let's just do a little bit about ECF and ICF. This is ECF here. This is ICF here. Now, which is the major cation? Major cation in the ECF is sodium. ICF is potassium. Major anion. Major anion in the ECF is chloride. ICF is proteins of phosphates. Proteins of phosphates, right? Here the miscellaneous phosphates are more than proteins. More than proteins. So your major anion in the ICF is going to be phosphates. Phosphates are more than proteins. Is it clear? So miscellaneous phosphates more than proteins. Right? Now this is the next what we can Once we discuss the basics about cell membrane, let's have a look at. No. Ludhiana, tight junctions will be present only in certain tissues. Certain tissues such as the intestinal epithelial cells, the PCT cells, the endothelial cells of the brain capillaries. So it will vary from tissue to tissue, right? Tight junctions are seen. These are the different types of junctions. Now these different types of junctions will depend upon the tissue to tissue, right? So tight junctions will be seen in, especially in, like I said, the intestinal epithelial cells, in the PCT, in the endothelial cells of the, isn't it? You have a question. See, blood-brain barrier. What is blood-brain barrier formed by? What is the major composition of the blood-brain barrier? What constitutes the blood-brain barrier? Is it A, astrocytes, or is it the tight junctions between the endothelial cells? So your answer is this: tight junctions between the endothelial cells forms the blood-brain barrier. So it will vary from tissue to tissue, right? Foot process of astrocytes, nahi Mumbai. Better answer is tight junctions between the endothelial cells. Both will contribute to blood-brain barrier, but better answer, endothelial cells. Tight junctions, right? Okay. Next, let's look at transport across the cell membrane. Transport across the cell membrane. Transport across the cell membrane is of two types. There is a passive transport and there is an active transport. Now, passive transport is what is known as a downhill transport. Downhill transport means this is a transport along an electrochemical gradient. This is a transport along an electrochemical gradient, right? So this is passive. Does it require energy? No. No energy is required. This is your passive transport, whereas active transport is a uphill transport. Uphill transport means it is against an electrochemical gradient. Do I need energy for this? Yes, energy is required. So that is an active transport. So passive, downhill, and along, this is, like I said, along an electrochemical gradient, whereas no energy is required over here. But for active transport, I need energy. Now let's see what are the different types of passive transport. In passive transport, you've got simple diffusion. Number 2, there is facilitated diffusion. Number 3, there is osmosis. And number 4, there is what is known as the non-ionic diffusion. Whereas active transport is of two types: primary active transport and secondary active transport. Primary and secondary active transport, right? So simple diffusion, facilitated diffusion, osmosis, these are the different types of passive transport, do not require energy, along an very important, it is along an electrical gradient as well as a concentration gradient, right? So simple diffusion, facilitated diffusion, osmosis, and non-ionic diffusion, whereas active transport is primary and secondary. Clear? Next, let's go on to simple diffusion. Let's discuss each one of these in detail because there are questions which are asked from all of them. So let's discuss simple diffusion. Now, what simple diffusion is? Simple diffusion is all respiratory gases. Simple diffusion, all respiratory gases move across the cell membrane by simple diffusion. All lipid-soluble substances, move by simple diffusion. All alcohols move by simple diffusion. All steroids move by simple diffusion. So these are the substances which move across the cell membrane by simple diffusion. They are lipid, respiratory gases, and all lipid-soluble substances. Alcohol, methanol, ethanol, glycerol, they move by simple diffusion, right? And for simple diffusion, there is something known as the Fick's law of diffusion. So let's discuss that. There is a Fick's law of diffusion. And this Fick's law of diffusion states that J is equal to minus dA delta C by delta X. J is equal to minus dA delta C by delta X. Now what is J? J is the net transport. What is D? D is the diffusion coefficient. Yes? What is A? A is the surface area. Delta C, concentration gradient. Delta X, thickness of membrane. Okay? So D is diffusion coefficient, A is surface area, J is net transport, D is diffusion coefficient, A is surface area, concentration gradient, delta X is thickness of membrane. So these are the factors which will affect transport across a cell membrane. Right? Diffusion coefficient. Now as far as diffusion coefficient is concerned, diffusion coefficient will be different for different substances. Different for different substances. Now diffusion coefficient depends on like I said, it is different for different substances. This diffusion coefficient depends on the lipid solubility of that substance. It depends on lipid solubility of that substance. In fact, this is the most important characteristic. Most important characteristic. This is lipid solubility. Right? Lipid solubility of the substance is the most important characteristic. Number 2, it depends upon the molecular diameter or the molecular size. And number 3, it depends on the molecular weight. Molecular diameter or the molecular size and the molecular weight. Right? In fact, the most important, this has been asked as a question, which is the most important characteristic of a substance which determines its movement across the cell membrane is lipid solubility. Now there was another question which had come, that if you have two equally lipid soluble substances, then the next important characteristic becomes molecular diameter or the molecular size. Two equally lipid soluble substances, then the next important characteristic is molecular diameter or the molecular size, and least important is molecular weight. In fact, the diffusion coefficient is inverse to the square root of the molecular weight. Have you got my point? It's square root of the molecular weight. Right? So this is most important characteristic, lipid solubility. If two equally lipid soluble substances, then the next important character. So order of importance is also 1, 2, 3. Lipid solubility most important, molecular diameter next, and molecular weight least important. So this is J is equal to minus dA delta C by delta X. Right? That means transport is directly proportional to diffusion coefficient, to surface area, to concentration gradient, and inversely proportional to thickness of the membrane. Right? Like for instance, see this. What happens now? Let's see what happens. This is a normal alveolar sac. Right? Now what happens in emphysema? Emphysema, there is breakdown of the alveolar walls. So surface area has now decreased. And what happens to the diffusing capacity? Diffusing capacity in emphysema reduces. Right? This is your effect of surface area. Right? Delta C, like I said, transport is directly proportional to concentration gradient, inversely proportional to thickness of membrane. Please understand that the negative sign over here, the negative sign has no mathematical significance. It's not a mathematically, it is only telling us what is the direction of movement. direction of movement is from higher to lower concentration. Then you use this negatives. This tells us that the movement is from higher to lower concentration. So this is what is the effect of this is what is the importance of the negative sign. Right? So this is your, if you've understood this fixed law of diffusion, by the way, fixed law of diffusion was asked in AIMS 2013. So this is an important point. Let me ask you a conceptual question. So please understand this is a pure conceptual question. So don't get into it and ask me why is it happened, how is it happened, how is this possible? That's not our purview. This is just a conceptual question. So what is this? This states that I have a membrane permeant substance. I have a membrane permeant substance. Membrane permeant substance, money, this is a lipid soluble substance. Membrane permeant substance whose intracellular concentration is 10 and outside is 5. Right? Membrane permeant substance, which is intracellular concentration is 10 and outside is 5. Now this substance diffuses from inside to outside. It goes from inside to outside, higher to lower concentration. ठीक है? Membrane permeant है, lipid soluble है. ठीक है? Now listen to this very carefully. Now intracellular concentration, thickness of membrane and surface area, they are doubled. Somehow we have increased the intracellular concentration, outside remains the same. We've doubled the thickness of membrane, we've doubled the surface area of the membrane. What will happen to the rate of transport? A, does it become 2 times? B, does it become 3 times? C, does it become half? D, does it become 1/3? Let me see. Mysore मेरठ बहुत जल्दी आंसर किया. थोड़ा सोच के करो. मुंबई थोड़ा सोच के. No. See, what is this? J is equal to minus dA delta C by delta X. Now supposing I have doubled the surface, I have doubled the surface area, I have doubled the thickness. Both of these will cancel each other out. Both have got doubled, one in the numerator, one in the denominator, so this is gone. That means what is going to determine the movement is delta C. What is delta C? Delta C is concentration gradient. Okay? Now, when the inside is 10, outside is 5, the gradient is 5. Inside को double किया. Outside, I told you, remains the same. So now it has become 20 minus 5, which is 15. How many times increase in the gradient? This is a 3 times increase. And we just decided that the rate of transport is directly proportional to the concentration gradient. Therefore, my answer becomes 3 times. फिर से सुनो. Question को ध्यान से देखो. It says, there is a membrane permeant substance whose intracellular concentration is 10, outside is 5. अब मैंने आपको ये कहा कि इंट्रासेलुलर कॉन्सेंट्रेशन को हमने डबल किया, थिकनेस ऑफ मेम्ब्रेन को डबल किया, सरफेस एरिया को डबल किया. What will happen to the rate of transport? Now see, what's happened is, when you look at this is J is equal to minus dA delta C. Doubling the area, doubling the thickness will cancel each other out. So they will have no effect. It is the concentration gradient, therefore, that will determine the change in the rate in transport. So let's see, let's have a look at the concentration gradient. 10 minus 5 is equal to 5. When inside was 10, outside was 5, gradient is 5. Inside ko double kiya. Remember I told you outside is still the same. So now the gradient becomes 20 minus 5, which is equal to 15. This is a 3 times increase in gradient. Therefore, the rate of transport will increase by 3 times. Tell me, have you all understood this question? If you can just write an okay, then I can take a little break for 10-15 minutes. Okay, great. So I think more or less all of us have understood this concept. Please understand, I put this question specifically to make us realize it is not the concentration which is important, but the concentration gradient. For movement of any kind of a lipid soluble substance, what is important is the concentration gradient. Okay? I'll take a break till 4:15. It's 4:03, and then we'll continue. Right? देख बेटा वो क्या लिखा है 12, 13 क्या लिखा है Let's go on to the next thing then, if there are no questions. Oh. See, cadherins and integrins. Cadherins, integrins, these are Hyderabad. These are cell adhesion molecules. These are molecules which help to bind the cells to one another. So these are your cell adhesion molecules, also known as CAMs. CAMs is cell adhesion molecules. So cadherins and integrins, and these are forms of are types of cell adhesion molecules. Mysore, there is a zona adherens, but a macular adherens, I'm not too sure what is this you're talking about. Zona adherens, definitely. Zona adherens is what I just told you. I told you at the and focal spots. I'm sorry, what is this in relation with? If you remember, we've done this. Zona adherens was somewhere here. Let me just see. Yeah, you are. We've done this here. This was the zona adherens. Zona adherens. Asymmetry of the cell membrane is mainly contributed by which factor? Asymmetry of the cell membrane? Is this an MCQ, Gorakhpur? What is this? Asymmetry of the cell membrane is mainly contributed by which factor? Asymmetry of the cell membrane? Proteins? Should be proteins. Is this an MCQ? Gorakhpur, could you please clarify? Can you give me the options here? I'm sorry, I don't understand. Asymmetry of cell membrane. What were the options? What is it with reference to? What were the options? Options, what were the options there? Asymmetry of cell membrane. So proteins, na? That's what I was telling you, proteins. Osmolar gap, Gulbarga, osmolar gap. See, osmolar gap is when you see the measured plasma osmolality, and if you see plasma osmolality with the help of, what is it? Plasma osmolality, when you see when you look at the one way to measure plasma osmolality is by measuring the freezing point of plasma, freezing point. See, because 1 milliosmol or 1 osmol of a solute decreases the freezing point. 1 osmol of a solute, 1 osmol of a solute, it decreases the freezing point of a solution, by 1.8 degrees Celsius. So that is why the freezing point of plasma is approximately minus 0.54 degrees Celsius. Yes. So osmolar gap is, see, normally you know that the major contributor to the osmolality is sodium, then contribution by glucose and urea. Right? So these are the 3 important ones which are contributing to the osmolality. Now, if you do a freezing point, if you take a sample of plasma and you find that the freezing point is lower than the calculated osmolality, the actual freezing point is lower than that means there is presence of some other substance which is contributing to the osmolality. See, normally when you are calculating osmolality, you measure sodium, urea, and glucose to give you the idea of osmolality. But when you take the freezing point of that particular sample of plasma and you find that it is lower than the actual freezing point, it's lower than the expected one. That means there is something else which is contributing to osmolality. So that's called an osmolar gap, and that is seen whenever, for example, in the presence when there is excess of ethanol, right? Or if there is something known as antifreeze. Yes, these are poisoning, different types of poisonings when there are substances other than these 3 main ones which are increasing the osmolality, and that is detected when you do a freezing point of that sample of plasma, right? Protein modification in the Golgi apparatus. Protein synthesis comes under the purview of biochemistry. They will tell you complete details about protein synthesis. So Mysore and Gorakhpur, you should not have a problem there. Agartala, please repeat osmotic adaptation. Osmotic adaptation, what I told you was osmotic adaptation is seen whenever there is a chronic hyper or hyponatremia, and this is seen whenever chronic hypo or hypernatremia, and this is seen in situations these are seen in situations wherever this osmotic adaptation is done by brain cells. Agartala, it's done by the brain cells. And how does the brain cell increase the osmolality? Inside osmolality, in the presence of sorry, I don't know where that. So osmotic chronic hypernatremia, like I told you, this is, here you will see osmotic adaptation. How does the brain cells osmotically adapt? There is increased intracellular synthesis of osmolytes and there is import of sodium. Both of these increase the intracellular osmolality so that there is no change in the plasma osmolality. Right? No change in the cell volume. No change in the cell volume. Outside osmolality is increased, inside also increases, so there is no change in cell volume. Right? After this, if there is a fall in plasma osmolality, if there is a hyponatremia, then the cells will decrease the intracellular osmolality. How? By decreasing the intracellular synthesis of osmolytes and by export of potassium. Jabalpur, I will try and write in the center of the page, but unfortunately, I have too much to write, and that is the reason why I. एक मिनट सुन मेरी बात सुन. Just give me 1 minute. Let me try and sort out this problem. ये देख इसमें ना it is ये जो पूरा ना स्क्रीन पे नहीं आता एक टाइम पर, और मैं बहुत लिखती हूँ तो फिर मेरे को इसको स्क्रीन पे कैसे लेके आए? इसको कम कर दे. ये देख आ गया पूरा स्क्रीन पे. वहाँ नहीं जाएगा. I'm just trying to sort out that problem, right? Meerut, Allahabad, all of you agree on. वो सेंटर उसको पेज की उसको ठीक से करो तो नहीं होगा. अगर कोई कम लिख रहा है ना फिर तो ठीक है, मैं लिखती बहुत ज़्यादा हूँ, तो मैं क्या करूँ, उनको सबको परेशानी हो रही है। कर दे मेरी शक्ल लगा दे बेशक।
बच्चे पढ़ेंगे नहीं मैम,
कोई नहीं। अग्रोहा आलोक, just 1 minute. क्या earlier classes it was NP क्या है यार, NP size was bigger. Notepad, okay. Notepad size cannot change, it's the same notepad. Agree. Okay, yeah, thank God somebody's asking me something. Now, explain what is value of 0.54. Now, what is this? What do I mean by that is, see, फिर क्या करूं, बीच में लिखो सिर्फ, हाँ? नहीं, एक टाइम पर पूरा स्क्रीन नहीं दिखा सकते। नहीं, ये देख, ये जैसे ये आ गया पूरा स्क्रीन, ये नहीं दिखा सकते क्यों? तो जाने दे मेरा फेस, मेरे को क्या एप्लीकेशन ऑलरेडी उसमें है ना, अटैच है, ये कुछ भी कर दो आप पूरा कर लोगे ना, तब भी आपका ये और ये साथ में दिखेगा उनको। नहीं, पूरा स्क्रीन नहीं दिखेगा एक टाइम पर, नोट इसका पूरा टेक नोट का पूरा स्क्रीन नहीं दिखेगा। अभी क्या हो रहा है ना, यहाँ पर लिख रही हूँ तो फिर वो शिफ्ट कर जाता है। ऑटोमेटिक चल रहा है ना? ऑटोमेटिक क्या होता है? नहीं, वो तो हो रहा है, लेकिन क्या हो जाता है, ये देखना, ये पूरी लाइन जो है यहाँ पर मिस गैप ये हो गया। एक्चुअली मेरा लिखने का काम बहुत ज़्यादा है। ऑलराइट, क्यों भाई, फैकल्टी वीडियो स्मॉल करो, क्यों? नहीं होगा, चलो, okay, it can't be sorted out, so I think there is a problem there, so I'll try and limit myself into the screen that is visible, so maybe that will try and sort out this problem, right? So somebody was asking me what is minus 0.54. What is this actually? See, this is 1 osmole of a solute will decrease the freezing point by 1.8 degrees Celsius. You know this, na? Solution has a lower freezing point than, let's say, water. A solution will always have a lower freezing point. So how much does a freezing point lower is 1 osmole of a solute decreases the freezing point by 1.86. The freezing point of plasma has an osmolality close to 300 milliosmoles. 300 milliosmoles. So that's approximately minus 0.54 degrees Celsius. That is what I was trying to tell you. What is the freezing point of plasma? Right? So next, let's go on to what we were discussing. We had finished with the simple diffusion, transport across cell membrane. I was discussing passive and active diffusion with passive and active transport. So passive transport, we said simple diffusion, where we discussed Fick's law of diffusion. And the second one, which I'm going to discuss with you, is what is known as facilitated diffusion. Now, facilitated diffusion. Now, what is facilitated diffusion? Facilitated diffusion, now here it is again movement of a substance from a higher to a lower concentration along a concentration gradient, but there is the presence of the carrier protein. there is a carrier protein which is involved. And because of this carrier protein, there are some important characteristics of this type of transport. And the first one is what is known as stereospecificity. And what is stereospecificity? It means the carrier protein is specific for a substance or a structurally similar substance. Carrier protein is specific for a substance or a structurally similar substance. Like for instance, GLUT. GLUT is the carrier protein for glucose. Now GLUT can transport glucose. It can also transport a structurally similar monosaccharide, and that is galactose. So stereospecificity is that the carrier protein is specific for a substance or a structurally similar substance. Like I told you, the example of GLUT. GLUT can transport both glucose as well as galactose. These are both structurally similar monosaccharides. In fact, this has been asked as a question also. Excess of which of the following in the gut can decrease the glucose absorption? Excess of which of the following in the gut can decrease the glucose absorption? And your answer becomes galactose. Okay? So this is stereospecificity. Second important characteristic of this mode of transport is saturation kinetics. And what do I mean by saturation kinetics? Saturation kinetics means, now the carrier protein can get saturated. Carrier protein can get saturated, therefore there is a Tm which is present, a transport maxima which is present. There is a maximum rate of transport. That is, if I see this graphically, if we have concentration gradient on the x-axis, and the rate of transport on the y-axis, a linear relationship, this sort of a linear relationship that you see, this is simple diffusion. That means more the gradient, more the rate of transport. But in facilitated diffusion, what do we find? We find there is, with increase in gradient, there is increase in the rate of transport, but after some time, there is going to be a maximum rate of transport. And what is responsible for this Tm? This Tm, or the maximum rate of transport, is because the carrier protein gets saturated. So this is the maximum rate of transport, right? And this Tm will be seen in all carrier mediated transports. All carrier mediated transports will show a Tm. And carrier mediated transports are of two types. Carrier mediated transports are of two types. It could be passive or it could be active. Passive carrier mediated transport, of course, is what we are doing right now, facilitated diffusion. Active carrier mediated transport could be primary or secondary active transport. So all carrier mediated transports will show a Tm, transport maxima, because the carrier mediated transport will get saturated. So it follows saturation kinetics. This is as far as your the important characteristics of facilitated diffusion. Facilitated diffusion is carrier mediated. It is there is something known as stereospecificity, which will be seen here. Number 3, I said there is a Tm which is present because the carrier protein gets saturated. Does facilitated diffusion require energy? No. This is a form of a passive transport. It will be along an electrochemical gradient, but no energy is required. Let's see what are the examples of the facilitated diffusion. Examples of facilitated diffusion, I've just described one to you, and that is GLUT, glucose transporter. Urea transport is also with the help of a carrier protein. This is urea transport is also facilitated diffusion. There are different types of urea transporters. You have UTA1, UTA2, UTA3, UTA4. These are present in the kidney. UTB, on the other hand, UTB is present on RBCs. So easy to remember. RBCs have UTB. UTA1 to A4 is present on the kidney, present in the kidney. These are your carrier proteins for the facilitated transport of urea. You also have amino acid transporters. Amino acid transporters on the basal side of cell. This is also another example of facilitated diffusion. So facilitated diffusion, I've told you there are 3 examples: glucose transport, urea transport, amino acid transport. This is facilitated diffusion. Next type of, so we've done 2 types of passive transport. We did simple diffusion, we've done facilitated diffusion. Difference between simple and facilitated: facilitated, there is a presence of a carrier protein, because of which there are certain other important characteristics which come in. The third type of passive transport is osmosis. And osmosis is very simple. Osmosis is basically the movement of water from a dilute to a concentrated solution. Movement of water from a dilute to a concentrated solution. Then last is what is known as non-ionic diffusion. Now, non-ionic diffusion is very, very specific. This is a cross-section of the collecting duct. Collecting duct, these are your collecting duct cells here. And these collecting duct cells can now produce ammonia. How do they produce ammonia? Is glutamine is broken down by the enzyme glutaminase to form ammonia. Glutamine is broken down to form ammonia by the action of the enzyme glutaminase. Now this ammonia, being a gas, it diffuses from the cells into the lumen of the collecting duct. And lumen of the collecting duct has the presence of H+. Ammonia acquires the H+ and becomes ammonium ion. Ammonia acquires the H+ and becomes ammonium ion. Mane ammonia ka diffusion was in a non-ionic form, but the moment it comes into the lumen, it becomes ionized. It becomes ionized and becomes ammonium ion. Ammonia diffuses from the cells into the lumen and becomes ionized. That means what is happening to ammonia concentration in the lumen? Decreases, right? So ammonia in the lumen will be in a low concentration because it has got converted to ammonium ion. So whatever ammonia is being synthesized in the cells will diffuse from the cells into the lumen, higher to lower concentration. This is called non-ionic diffusion. Diffusion of ammonia was in a non-ionic form, but the moment it comes into the lumen, it becomes ionized, right? So this is the secretion of ammonia. So the examples of non-ionic diffusion, like the ones which I just told you, there is secretion of ammonia by the collecting duct cells, right? By the collecting duct cells. Then there's also excretion of weak acids. Weak acids, like for instance salicylates, by the salicylates, aspirin group of drugs. This is also excretion of these weak acids is also by the kidney. By the kidney, this is also an example of non-ionic diffusion. Then absorption of weak acids and weak bases. In the stomach, this is also by the process of non-ionic diffusion. Then another example of non-ionic diffusion I see in the distal ileum. Distal ileum, there is absorption of bile salts. Absorption of bile salts in the distal ileum. This is also another one which is responsible for what is known as this is also another example of non-ionic diffusion. So these are examples of non-ionic diffusion, that is secretion of ammonia, excretion of weak acids, absorption of weak acids and weak bases, and absorption of bile salts in the distal ileum. If you can just see what happens in the bile salts, what happens in distal ileum. For example, if this is the jejunum, this is the ileum here, this is the colon. Now what is absorbed from the distal ileum are two things. There is the absorption of B12 and there is the absorption of bile salts. Now, bile salts, the major mechanism of absorption of bile salt, there is a sodium bile salt co-transport. This is a secondary active transport. And the second mechanism is the non-ionic diffusion. Non-ionic diffusion. Right? Please understand the major mechanism of bile salt absorption is sodium bile salt co-transport, and the minor mechanism is non-ionic diffusion. So again, a question which was asked last year in your All India PG exam, non-ionic diffusion can be seen in A, stomach, B, kidney, C, distal ileum, D, all of the above. So again, all of the above. Another question which was asked related to this topic in last year's exam, non-ionic diffusion can be seen in only stomach, only kidney, stomach and kidney. So your answer becomes stomach and kidney. Absorption of salicylates in the stomach, one of the mechanisms is non-ionic diffusion. Kidney में तो मैं आपको बता ही चुकी हूँ, and distal ileum में absorption of bile salts. So these are examples of non-ionic diffusion. So we've done 4 types of transport, passive transport. There was simple diffusion, where we discussed the fixed law of diffusion, then facilitated diffusion, osmosis and non-ionic diffusion. Next, let's go on to active transport. Let's see active transport. Active transport. Active transport general characteristics I already told you. This is a carrier mediated transport, has to be. It is uphill transport against an electrochemical gradient, requires energy. So these are your characteristics of active transport. There is primary and there is secondary. So let's discuss examples of primary active transport. The most important example of primary active transport is your sodium potassium pump. Sodium potassium pump. Second, H plus K plus ATPase pump, also known as the proton pump. And this is seen in the parietal cells of the stomach. Parietal cells of stomach. This is also seen in the collecting duct of the kidney. So you see these proton pumps, parietal cells of stomach and also in the collecting duct of the kidney, right? This is H plus K plus ATPase. Third example is what is known as SARCA, sarcoplasmic endoplasmic reticulum calcium pump. Sarcoplasmic endoplasmic reticulum calcium pump. Where is this present? This is in skeletal muscle and this is in cardiac muscle, right? Skeletal as well as cardiac muscle. We'll do this as we do when we do muscle, right? But for the time being, I need to discuss with you sodium potassium pump in detail. So let's discuss this. Sodium potassium pump. Now, sodium potassium pump, it is present in almost all the cells of the body, right? And what is this sodium potassium pump? The first thing is, what does it do? Sodium potassium pump, it pumps out 3 sodium and brings in 2 potassium. Pumps out 3 sodium and brings in 2 potassium. Right? 3 sodium is pushed out of the cell, 2 potassium is brought into the cell. So this is my first question. And please remember, see, whenever I shade a carrier protein, that means it has got ATPase activity. It has got an ATPase activity. If I shade a carrier protein, it has got ATPase activity. If a carrier protein is unshaded, means it's a facilitated diffusion. Have you understood? Or it does not require energy, right? It does not have ATPase activity. So this is your sodium potassium pump, which has got ATPase activity. My first question is, what is the coupling ratio? What is the coupling ratio of the sodium potassium pump? Is it 3:2? Is it 2:3? And your answer becomes 3:2. 3:2 is the coupling ratio of the sodium potassium pump. 3:2. Manikya, why not 2:3? Why can't I call this a potassium sodium pump? Right? It's always 3:2. The reason for this is the movement of sodium and potassium is a two-stage process. This is a two-stage process. What does a two-stage process mean? That means पहले 3 सोडियम बाहर जाएगा, फिर 2 पोटेशियम अंदर आएगा. It is not a simultaneous movement. It is a two-stage process. 3 sodium go out of the cells and 2 potassium is brought into the cell. So this is why I said it is a two-stage process. So coupling ratio will always be 3:2 and the name of this pump will always be sodium potassium pump. पहले 3 sodium बाहर जाएगा, फिर 2 potassium अंदर आएगा. So that is your coupling ratio. Next important point about the sodium potassium pump. Next important point is that it is an electrogenic pump. And what is an electrogenic pump, Mane? Electrogenic pump, Mane, there is 3 sodium go out of the cell, 2 potassium are brought inside. That means there is a net loss of one osmotically active particle. There is a net loss of one osmotically active particle. Net loss of one osmotically active particle. That means this becomes an electrogenic pump. This is an electrogenic pump, right? There is net loss of one osmotically active particle. It is an electrogenic pump. Mane, now what has happened because of net loss of one osmotically active particle? Inside of the cell has become negative with respect to outside. Isn't it? 3 positive charges towards the, here I wouldn't use the term osmotically active particle. I meant here the net loss of one positive charge. That is what I meant here. I can just amend that, please. Net loss of one positive charge. Net loss of one positive charge causes the inside to become negative with respect to outside, right? 3 positive charges have gone outside and 2 positive charges have come inside. So there is a net loss of one positive charge causing the inside to become negative with respect to outside. That's why I call it an electrogenic pump, right? This is, if you remember, negative with respect to outside is what is your resting membrane potential, right? In other words, the sodium potassium pump contributes to the resting membrane potential. Now the question arises, how much is this contribution to the resting membrane potential? How much is the contribution? The sodium potassium pump contributes -4 millivolts. The contribution is very little, -4 millivolts. It contributes only -4 millivolts to resting membrane potential, especially if the resting membrane potential is -90 millivolts. The contribution of the sodium potassium pump is hardly anything, just about -4 millivolts, right? In other words, if I ask you a question which says, what is the main function of the sodium potassium pump? A, is it resting membrane potential? Or B, is it cell volume regulation? My answer becomes cell volume regulation, not the resting membrane potential, because you know already that the contribution to resting membrane potential is very slight. It's only contributing minus 4 millivolts in cells where the resting membrane potential is minus 90. That means resting membrane potential is mainly due to something else. Clear? It is therefore the main function is cell volume regulation. Cell volume regulation is the main function of the sodium potassium pump. Now, how does it help in cell volume regulation? This sodium potassium pump has, what has it done? It has pumped out 3 osmotically active particles have gone out of the cell, and 2 osmotically active particles have come into the cell, right? Now, cell volume regulation, so how does it, let me just try and explain this a little more. See, the cell membrane at rest is impermeable to sodium, right? It does not allow the sodium to come from outside to inside the cells. Outside sodium is very high, right? But it does not allow the movement of sodium. But cell membrane hai, biological structure hai, and all biological structures are not perfect structures. Yes? So what happens is there is leakage of small amounts of sodium from outside to inside over a period of time. And sodium is osmotically active. Mane? Now sodium comes from outside to inside the cell. Iske piche water will enter into the cells. And cells will now start swelling up, and a stage will come where the cell will burst. But please understand, it is a leakage of sodium, right, from outside to inside the cells. Now, how does the sodium potassium pump prevent this increase in cell volume? This is by it pumps out 3 osmotically active particles, brings in 2 osmotically active particles. Mane, there is now a net loss of 1 osmotically active particle. There is a net loss of 1 osmotically active particle, and this helps to maintain the cell volume. There is a net loss of 1 osmotically active particle, and this helps to maintain the cell volume. So this is your function. So like I said, the important question, let's see this. Here you are. What is the main function of the sodium potassium pump? Is it resting membrane potential or cell volume regulation? Answer will be cell volume regulation. Contribution to resting membrane potential minus 4 millivolts only. Cell volume regulation by a net loss of 1 osmotically active particle. Chaliye. After this, after we've done the coupling ratio of sodium potassium pump, its contribution to resting membrane potential, and what is the main function of the sodium potassium pump. Now, sodium potassium pump is a heterodimer. This is a heterodimer. Heterodimer means it has got 2 subunits, both are different from each other. There are heterodimer, right? And there are 2 of them, alpha and beta. So let's discuss this. This is the beta subunit, right? And here is the alpha. Alpha is the larger one, almost twice the size of beta. And this is the cell membrane here. Right? Now this alpha subunit on the inside has got 3 binding sites, and towards the outside has 2 binding sites. Now this is the ECF here, this is the ICF. So it has 3 binding sites on the inside and 2 binding sites on the outside. The 3 binding sites are: number 1, sodium binding site, number 2, ATP binding site. And number 3, phosphorylation site. Sodium binding site, ATP binding site, and phosphorylation site. Now, what is this phosphorylation site is? See, this ATP, the alpha subunit has got the ATPase enzyme. So ATP is broken down to form ADP plus inorganic phosphorus plus energy. It has got the ATPase enzyme. This phosphorus which is generated now goes to the phosphorylation site. And this phosphorylation site is nothing but aspartate at 376 position. Question: which is the phosphorylation site? It is aspartic acid or aspartate at 376th position. This is your phosphorylation site, aspartate at 376 position. ये हो गए आपके 3 binding sites on the inside. Outside you've got 2 binding sites. You can see them, there are 2 here. Number 1 is the potassium binding site. Potassium goes from outside to inside, lower to higher concentration. And number 2 is the ouabine binding site. And what is ouabine? Ouabine is a plant glycoside. It is a plant glycoside, and in fact digitalis is derived from ouabine. Ouabine is a plant glycoside, and in fact digitalis, like I said, is derived from ouabine. And what is the function of digitalis? What does digitalis do? Digitalis or ouabine, they inactivate the sodium potassium pump. So if you have noticed by now that all the binding sites are on the alpha subunit. Alpha is the larger one and has all the binding sites on it. It does all the function of the sodium potassium pump. Now, as far as the beta subunit is concerned, beta subunit, like I told you, is the smaller one. It's almost half the size of the alpha subunit. Beta subunit is a glycosylated protein. Beta subunit, this is a glycosylated protein. And this beta subunit has got 3 extracellular glycosylation sites. It has 3 extracellular glycosylation sites. Please understand, these glycosylation sites have no function. They are only a part of the structure of the beta subunit, right? So this is a beta is a glycosylation. That means one All India PG question. All of the following are present on the alpha subunit except sodium binding site, potassium binding site, phosphorylation site, glycosylation site. So your answer becomes glycosylation site. Glycosylation sites are on beta subunit. What is the function of the glycosylation sites? It is only a part of the structure of the beta subunit. There is no function as such. Functioning is done by the alpha subunit and these different binding sites on the alpha. So this is as far as your structure of the sodium potassium pump is concerned, right? So we've done the coupling ratio. We've done how it is an electrogenic pump. We discussed what is the main function of the sodium potassium pump. We've done the structure. It is a heterodimer and alpha and beta subunit. Alpha is a larger, does all the functions of the sodium potassium pump. Next, let's see what are the hormones which affect. hormones which affect the sodium potassium pump. Now, as far as the hormones which affect the sodium potassium pump are, number one, thyroid hormones. Thyroid hormone increase the number of the sodium potassium pumps. Number two is aldosterone. Aldosterone increases number, it increases the activity. It increases number, it increases the activity. Thyroid only increases the number. Aldosterone not only increases the number of sodium potassium pumps, it also increases the activity of the individual sodium potassium pumps. Insulin increases the activity without affecting the number, right? Common example, na? Whenever you have a patient of diabetic ketoacidosis, you've given him IV insulin, one of the most common complications will be hypokalemia. Why? Because now increased activity of the sodium potassium pump causes movement of potassium from outside to inside the cells, and potassium, which is as it is serum potassium levels, are very low. They're hardly 3.5 to 5 millimoles per liter or milliequivalents per liter. So when potassium moves from outside to inside the cells, a decrease in serum potassium levels. This is a common complication, hypokalemia, common complication of IV insulin, isn't it? Number 4, dopamine and atrial natriuretic peptide. Both of them decrease the activity of the sodium potassium pump. And this has been asked as a question in DNB this year. And this is increase in activity of sodium potassium pump is seen by all except thyroid hormones, aldosterone, insulin, या dopamine. So our obvious answer becomes dopamine, right? Thyroid hormones, of course, we know that it has a specific function. What does it do? It increases the number. But number बढ़ने का मतलब है, it increases the number, but that means it's also increasing. If increases the number, that means it increases the functioning or whatever is the role of sodium potassium pump increases. In other words, it is also increasing the activity. But of course, when I talk in terms of I've told you in detail which one actually affects the activity of the individual sodium potassium pump, right? But overall activity, like I said, it is increased by all of these except dopamine. Dopamine decreases the activity, right? So this is as far as the hormones which affect the sodium potassium pump are concerned. Now, sodium potassium pump, we've done it in a lot of detail and a lot of questions have been asked from here. And so let's be ready with whatever with sodium potassium pump. Now, after this, let's have a look at secondary active transport. Secondary active transport. Now, as far as secondary active transport is concerned, this is dependent on the primary. इसका नाम ही secondary इसलिए है because it is dependent on the primary. माने अगर primary active transport does not occur, does not take place, then secondary also will not occur. It is dependent on the primary. So let's discuss this. Let's see this on the intestinal epithelial cell. This is an intestinal epithelial cell. This is the brush border here. Refill. Refill. Secondary active transport. Now this is the name secondary. That means it is dependent on the primary. It is dependent on the primary, right? It is dependent on the primary. And here, this is the basal side of the cell. Basal side of the cell. Now on the basal side of the cell, you have the activity of the sodium potassium pump. This now pumps out 3 sodium and brings in 2 potassium, right? So it pumps out 3 sodium and brings in 2 potassium, right? माने activity of the sodium potassium pump, what has it done to the intracellular concentration of sodium? Decreases it. Now, inside sodium is less as compared to outside. In other words, it has created a concentration gradient for sodium. Inside sodium is less. Plus, the activity of the sodium potassium pump has created a negativity inside the cell with respect to outside. And sodium, you know, is a positively charged ion. So, in other words, the activity of the sodium potassium pump has created an electrochemical gradient for sodium. So, what happens on the opposite side of the membrane? On the opposite side of the membrane, now sodium moves from outside to inside the cell along its electrochemical gradient created by, and who has created this electrochemical gradient? This has been created by the activity of the sodium potassium pump. So sodium moves along its electrochemical gradient created by the sodium potassium pump. And this movement of sodium provides the energy for active transport of some other substance. If that substance is in the same direction as sodium, it is called a co-transport or a symport. And if it is in a direction which is opposite to the movement of sodium, this is a counter-transport or an antiport. Please understand, the secondary active transport is linked with the movement of sodium. Sodium is moving along its electrochemical gradient, and this electrochemical gradient has been created by the activity of the sodium potassium pump. The sodium potassium pump decreases the intracellular concentration of sodium, plus it makes the inside negative with respect to outside. So sodium moves along its electrochemical gradient created by primary, and the movement of sodium provides the energy for active transport of some other substance. If that other substance is in the same direction as sodium, co-transport, opposite direction as sodium, counter-transport. So this is your secondary active transport. So let's see what are the examples of co-transport and counter-transport. Let's see co-transport first. Co-transport examples, like for instance, you've got the sodium co-transport is, for example, the sodium glucose co-transport, sodium amino acid co-transport. This is what you see in the small intestine. This is seen in the GI tract. Sodium glucose co-transport, sodium amino acid co-transport. You not only see in the GI tract, you also see in the PCT cells of the kidney, right? You also see what is known as sodium inorganic phosphorus co-transport in the PCT, right? Sodium inorganic phosphorus co-transport. Then remember, I just told you a little while back, sodium bile salt co-transport. This is what you see in the distal ileum, right? Another example of sodium bile salt. Then sodium iodide symport. This is in the thyroid cells. In the thyroid cells, sodium iodide symport in the thyroid cells. Right? This is a secondary active co-transport of iodide. They're linked with movement of sodium. And sodium, movement of sodium is dependent on the sodium potassium pump. Sodium potassium pump creates an electrochemical gradient for sodium. Sodium moves from outside to inside and transports another substance with it. This is co-transport. Counter-transport के examples देखिए. Counter-transport, you have in the PCT cells काउंटर ट्रांसपोर्ट, यस. एंटीपोर्ट के एग्जांपल्स देखिए, ये कौन से हैं? पीसीटी सेल्स में है sodium H plus. This is in the PCT cells. Sodium moves into the cells and H plus moves out of the cell. So Na plus H plus. Then you have a sodium calcium counter transport in the myocardial cells, right? So these are examples of counter transport, right? Now let's see at least one clinical application. For example, in the myocardial cell, this is a myocardial cell here, right? This is a myocardial cell. Now you have the activity of the sodium-potassium pump, which creates an electrochemical gradient for sodium. On this side of the membrane, you have a sodium-calcium countertransport. Right? This is a myocardial cell, sodium-calcium countertransport. Now, I give this patient digitalis. And if you remember, I told you a little while back that digitalis is derived from ouabain. Ouabain or digitalis, they inactivate the sodium-potassium pump. So, this is the action of digitalis here. Digitalis inactivates the sodium-potassium pump. If it inactivates the sodium-potassium pump, तो ये sodium-calcium countertransport नहीं होगा. And sodium calcium counter transport नहीं होगा तो intracellular calcium increase कर जाएगा. There will be increase in intracellular calcium, and when there is an increase in intracellular calcium, it increases the force of contraction, and that is the mechanism of action of digitalis. Digitalis inactivates the sodium potassium pump. Inactivates the sodium-potassium pump, increases the intracellular calcium, which in turn increases the force of contractions. This is the action of digitalis, right? Now take another example, another clinical aspect or important, not really clinical, another important example, and that is, let's say in the PCT of the kidney, right? PCT of the kidney. Now again, the basal side of the cell is here, yes? Basal side, you have the activity of the sodium-potassium pump, 3 sodium, 2 potassium. On the opposite side, you've got a sodium inorganic phosphorus co-transport. Now, you know parathormone. Parathormone acts on the PCT. And what does it do? See, what is the effect of parathormone on serum calcium levels? It increases serum calcium levels. What is the effect on serum phosphorus levels? It decreases it. It has what is known as a phosphaturic action. And this is how. Parathormone inhibits the sodium inorganic phosphorus co-transport. So it has what is known as a phosphaturic action. It decreases the serum phosphorus levels. This is the phosphaturic action. Clear? Sodium inorganic phosphorus co-transport is inhibited. It increases the loss of phosphorus in the urine. This is known as the phosphaturic action of parathormone. Phosphaturic action of parathormone. Are we clear with this? Right? So these are two interesting examples of secondary active. One was secondary active counter transport, which has got inhibited by the action of digitalis, and this one I told you is the action of parathormone on sodium inorganic phosphorus. And just for the sake of completion, there are two proteins, sodium inorganic phosphorus 2A and sodium inorganic phosphorus 2C. These are both present in the PCT. But the main action of parathormone is on sodium inorganic phosphorus 2A protein. This can also be asked as a question and you should be ready to answer it. Parathormone acts mainly on sodium inorganic. It's a subtype, right? 2A and 2C, so it acts mainly on 2A. Now, Ludhiana, you said alcohol. Please remember, alcohol is a lipid-soluble substance. Alcohol does not need a carrier transport for absorption. Have you understood? It is not linked with sodium. Alcohol is lipid soluble. It can easily cross the cell membrane. And I'm sure you can correlate it with practical example as well. Alcohol is one substance which is very rapidly absorbed. Yes, and I'm sure you can vouch for it by at least maybe observing others around you, right? So it is very rapidly absorbed because it's a lipid soluble substance. Does not need sodium for absorption. Okay. Next, let's see. After we've done the primary and secondary active transport, another mode of transport is what is known as exocytosis and endocytosis. So let's discuss this. Now, what is exocytosis? Exocytosis, now for instance, if this is the cell here, supposing there is vesicles here, and the contents of this vesicles have to be exocytosed. So what happens is, the vesicle attaches to the cell membrane like this. Then after some time, this is what happens, and the contents are exocytosed, right? So my first point here is, what happens to the total area of cell membrane? The total area of cell membrane here increases. Total area of cell membrane increases. Yes, why? Because the vesicular membrane has become a part of the cell membrane, right? Now for exocytosis, what do I need? I need number one, calcium. I need ATP. I need some proteins, and these proteins are what are known as docking proteins. Docking proteins. And these docking proteins are syntaxin, also known as the T-snare protein, syntaxin or the T-snare protein, synaptobrevin or the V-snare protein. Syntaxin, synaptobrevin and SNAP25. These are the docking proteins which are required for exocytosis. Syntaxin, synaptobrevin and SNAP25. Now let's see a clinical application here. What is this clinical application? See, neuromuscular junction. Neuromuscular junction, you've got, here is your neuromuscular junction, alpha motor neuron, muscle fiber, right? This is the A alpha motor neuron. And whenever this neuron receives impulses, there is release of acetylcholine, right? And acetylcholine combines with its receptors on the motor end plate, and that is called transmission across the neuromuscular junction. Now, botulinism or the botulinum toxin, what does it do? Botulinum toxin, it inactivates all these docking proteins. This is the action of botulinum toxin. And this acts at the neuromuscular junction. It inactivates all three docking proteins. So what happens here? Mane? Now it inactivates the docking proteins. So will there be exocytosis of acetylcholine? No. So what is the type of paralysis I see in botulinism? Botulinism produces what is known as a flaccid paralysis. Flaccid paralysis. Botulinism produces a flaccid paralysis because there is no release of acetylcholine, because what has botulinism done? Botulinum toxin done? It has inactivated all the three docking protein, syntaxin, synaptobrevin, SNAP25. Clear? So this is your exocytosis. Now, exocytosis is of two types. There are two pathways. There are two pathways of exocytosis. Number one is what is known as the non-constitutive pathway. Non-constitutive, or also known as the regulated pathway. Non-constitutive or the regulated pathway, and obviously the second one becomes the constitutive pathway. So non-constitutive or the regulated pathway first. Now what is this non-constitutive pathway? This is the moment there is synthesis of a hormone, enzyme, or a neurotransmitter. Synthesis of hormone, enzyme, or neurotransmitter is followed by processing, followed by storage, and then a release. Synthesis of a hormone, enzyme, or a neurotransmitter is followed by processing of that enzyme, hormone, or neurotransmitter, followed by storage, and then release. Then when the gland is given when that particular gland is given a stimulus, then there is release. Right? Now, synthesis of, like for instance, the synthesis of or the secretion of insulin. पहले क्या बना? Pro-insulin, then pro-insulin, then insulin plus C-peptide, right? So example of non-constitutive pathway would be secretion of insulin by the beta cells of pancreas. Secretion of insulin by the beta cells of pancreas, right? So there is a synthesis, there is a processing, there is a storage, and then there is a release. Pro-insulin, then insulin plus C-peptide, right? Similarly, secretion of glucagon by the alpha cells of pancreas, again a non-constitutive pathway. Or the secretion of enzymes by the pancreatic cells, by the pancreatic acinar cells. This is also a secretion of enzymes by pancreatic acinar cells. These are also examples of non-constitutive pathway. They're synthesized and stored. Okay? Or the secretion of neurotransmitters. Acetylcholine, exocytosis of acetylcholine, non-constitutive pathway. It is synthesized and stored. मतलब synthesis के बाद storage होना जरूरी है. It may be followed by processing, it may not be followed by processing. But wherever there is a storage, that becomes my non-constitutive pathway. Now, as far as the constitutive pathway is concerned, this is Chalo. Okay. Sorry for that little bit of interruption. So let's see. What I was talking about. This is constitutive pathway now. I was talking about the constitutive pathway. Now, as far as constitutive pathway is concerned, constitutive pathway means there is now a synthesis and a release. There is neither a processing nor a storage. There is neither a processing nor a storage. Synthesis followed by release. Right? Now, this is, for example, the secretion of immunoglobulins. Immunoglobulins by the plasma cells. Secretion of immunoglobulins by the plasma cells. Or the secretion of collagen by the fibroblasts. Collagen by the fibroblasts. So this is your non-constitutive and a constitutive pathway. So constitutive pathway, there is synthesis and a release, and this will be immunoglobulins by the plasma cells or collagen by the fibroblasts. So this is a very interesting question which can come out of here. Which of the following is a non-constitutive pathway? So you should be able to understand that wherever there is a processing or a storage, it becomes a non-constitutive pathway, and where there is synthesis followed by a release, it becomes a constitutive pathway. Now, this is as far as your non-constitutive and constitutive pathway is concerned. Right. After this, let's have a look at, now herein I'd like to discuss one AIMS question which was asked last year, November 2013, and that was, if there is a micropuncture of the cell membrane, how does this micropuncture get sealed? How does this micropuncture get sealed? And the answer is, this is by lateral movement. This is by, how does this micropuncture get sealed? See, supposing you do a micropuncture with the help of a needle, right? Microneedles, there is a micropuncture which is done. How does this get sealed? Now, this is what happens is, to seal this gap, lipids will flow from the side of this puncture. Lipids will flow from the side of the puncture, and they will form hydrophobic bonds which will seal this micropuncture. Right? So micropuncture of the cell membrane is sealed by, number one, there is by the flow of lipids. There is a flow of lipids from the side of the puncture. And these lipids now form the hydrophobic bonds. They form the hydrophobic bonds. Right? So lipids flow from the side of the puncture and they form hydrophobic bonds. So this is how micropunctures are sealed. Micropunctures are sealed. Right? But if it is a macropuncture, larger puncture, how does this happen now? How does a larger gap get sealed? This is by a calcium-mediated exocytosis. Calcium-mediated exocytosis of vesicles stroke lysosomes. Now, what is this calcium-mediated exocytosis? See, here is a gap. Here is a large puncture. You've got these vesicles inside the cell. Yes. Now, these vesicles will go and these vesicles will go and lodge here. Yes. And after some time, what do I get? There you are. Now the vesicular membrane has become a part of the cell membrane. So the gap has got sealed. So please understand, if it is a macropuncture, it is by exocytosis of vesicles or lysosomes. Have you understood? There is exocytosis, a calcium-mediated process. We've already discussed that. For exocytosis, I need calcium. This is a calcium-mediated process. The vesicle now docks with the cell membrane. It docks with the cell membrane, and now the vesicular membrane becomes a part of the cell membrane. right? It becomes a part of the cell membrane. So the gap has got sealed. But if it is a micropuncture, what is it going to be? It is by flow of lipids from the site of the puncture, and these form the hydrophobic bonds. Now, this is as far as your last year's AIMS question is concerned. So we've discussed exocytosis. Let's have a look at endocytosis. Now, what is endocytosis? Endocytosis. Supposing this is a substance which has to be endocytosed. So what happens now is that the cell membrane grows around it. Then after some time, what do we find? This here, right? And now this endocytotic vesicle detaches from the cell membrane. It detaches from the cell membrane. So what do I get? After some time, I get an endocytotic vesicle with the substance that has been endocytosed. This is endocytosis which has occurred. Cell membrane grows around it, forms a vesicle, vesicle detaches from the cell membrane, endocytosis. In other words, if I ask you what has happened to the total area of cell membrane, in this case, the total area of cell membrane decreases. Exocytosis it was increasing, but here it is decreasing, right? Now, what do I need for endocytosis? I need calcium, I need ATP, I need proteins. And which are these proteins? Number one is clathrin. Clathrin. And clathrin is required for receptor-mediated endocytosis. Receptor-mediated endocytosis. In fact, this is a question which has been asked. Which is the protein required for receptor-mediated endocytosis? And your answer becomes clathrin. Number two, clathrin is the protein required for receptor-mediated endocytosis. Another protein which is required is caveolin. Caveolin. And this is present in endothelial cells. Endothelial cells for absorption of nutrients. It is present in endothelial cells for absorption of nutrients. Caveolin. Another protein which is required is dynamin or pinchase. Dynamin or pinchase. Dynamin or pinchase is required. See, when this endocytotic vesicle is formed, to detach it from the cell membrane, I need the presence of dynamin or pinchase. Clathrin, which is receptor-mediated endocytosis, caveolin, this is in endothelial cells for absorption of nutrients, and dynamin or pinchase, right? This is as far as your receptor-mediated endocytosis is concerned. Please understand, Ludhiana, this is specific. This is for receptor-mediated endocytosis. Clathrin is required for receptor-mediated endocytosis. See, let me discuss the types of endocytosis with you now. The types of endocytosis are, number one, phagocytosis, cell eating. Then you have pinocytosis, which is cell drinking. Then you have a clathrin-mediated endocytosis. Clathrin-mediated endocytosis, which is your receptor-mediated endocytosis. Number 4 is your caveoli-dependent endocytosis. And caveoli-dependent endocytosis, I've already discussed it with you. Where do you see this? This is in endothelial cells for the absorption of nutrients. And 5 is, there is also a non-clathrin non-clathrin, non-caveoli endocytosis. Now, what are the details of this type of endocytosis? We still do not know. But there has been classified that there is a fifth type of endocytosis. Right? So there are these 5 types. Clathrin mediated is very, very specific. It is for receptor mediated endocytosis. And caveoli dependent endocytosis, endothelial cells. And number 5, like I said, non-clathrin, non-caveoli endocytosis. So this is your endocytosis here. So we've discussed exocytosis, endocytosis in a lot of detail. Right? And again, questions which have been, questions which can be asked from there. Next, let's take on another important part of general physiology, and that is Donan effect. So let's discuss that. What is the Donan effect? What is the Donan effect? Now, Donan effect is seen whenever you have 2 compartments, X and Y, and these are separated by a semi-permeable membrane. Two compartments X and Y, and these are separated by a semi-permeable membrane. Right? 2 compartments X and Y separated by a semi-permeable membrane, and on one side of the semi-permeable membrane are the presence of proteins. Proteins are present on one side of the semi-permeable membrane. So you've got 2 compartments X and Y which are separated by a semi-permeable membrane, and on one side of the membrane is the presence of proteins. And what are these proteins? These proteins are impermeant and negatively charged. Impermeant and negatively charged. They're impermeant anions. Impermeant means they cannot cross the cell membrane, and they're negatively charged, so anions. Okay? So Donan effect के लिए 2 चीजें चाहिए. Number 1, 2 compartments X and Y separated by a semi-permeable membrane, and on one side of the membrane is the presence of proteins. Proteins which are impermeant and negatively charged. Now let's talk of now there are 2 ions to which this membrane is permeable. 2 diffusible ions, and that is potassium and chloride. Right? Now, impermeant means it cannot go across the cell membrane. Right? The cell membrane is not permeable to proteins. So proteins cannot go across the cell membrane. They will stay in compartment X. Clear? So, like I said, we will talk of 2 ions. What was the effect of these proteins on 2 diffusible ions, that is potassium and chloride? Yes? To begin with, let's see that potassium in compartment X and Y and chloride in X and Y is equal. Right? They are equal. On both sides of the membrane, the concentration of potassium, and let's consider. Right? This is not what happens really, but let's take it that they are equal on both sides of the cell membrane. Now you know that the like charges repel and unlike charges attract. So what happens is, now potassium being a positively charged ion, the proteins now pull the potassium towards itself, so that at equilibrium, सबसे पहले तो what is equilibrium? At equilibrium, what is equilibrium? Equilibrium, does it mean equal concentration on both sides, or does it mean no net transport? Equal concentration on both sides or no net transport? What is equilibrium? No net transport. So at equilibrium, what do we find? We find K plus in compartment X is more than in compartment Y, and chloride in compartment X is more than is less than in compartment Y. It makes sense now? Proteins ने potassium which is positively charged उसको attract किया. So at equilibrium we find potassium more in compartment X as compared to compartment Y, and proteins being negatively charged repelled the chloride. So you have less chloride in compartment X and more in compartment Y. Right? So this is what is known as the Donnan effect. This is known as the Donnan effect, right? So for Donnan effect, I need two things. Number one, semi-permeable membrane and the presence of proteins on one side of the membrane. And number two, what is the result of Donnan effect? We find at equilibrium more will be the positively charged diffusible ions, potassium on in compartment X and more chloride in compartment Y. So there's an unequal distribution of ions, right? And where do I see this Donnan effect? I will see it between the intracellular and extracellular compartments. You have a semi-permeable membrane between them. You have more proteins inside the cell. So Donnan effect will be seen between intracellular and extracellular compartments. And number two, even intravascular and extravascular compartments inside the blood vessels and outside the blood vessels. That means intravascular and the interstitial fluid. Again, in the intravascular compartment, I have more proteins. So more potassium inside in the plasma as compared to the interstitial fluid, more chloride in the interstitial fluid as compared to the plasma, right? So this is the areas where I see this Donnan effect. Now the next which comes in is this distribution of ions which you see at equilibrium, it is not random. There is a mathematical relationship, and this mathematical relationship is given by the Gibbs-Donnan equation. Gibbs-Donnan equation. This Gibbs-Donnan equation states that at equilibrium, ratio of K plus in X over K plus in Y is equal to Cl minus in Y over Cl minus in X. Ratio of K plus in X over K plus in Y is equal to Cl minus in Y over ratio of Cl minus in Y over Cl minus in X. Let's see this. The ratio of K plus in X over K plus in Y is equal to Cl minus in Y over Cl minus in X. This is your ratio, this is the equation for distribution of ions at equilibrium. Distribution of ions at equilibrium, right? If you cross multiply these, इनको cross multiply करें, then what happens? Now you get K plus in X into Cl minus in X is equal to K plus in Y into Cl minus in Y. Product of, that means the product of diffusible ions, K plus in X into Cl minus in X, product of diffusible ions on one side of membrane is equal to the product of diffusible ions on the other side of membrane. This is your Gibbs-Donnan equation. K plus in X into Cl minus in X is equal to K plus in Y into Cl minus in Y. Product of diffusible ions on one side of membrane is equal to the product of diffusible ions on the other side of membrane. This is your Gibbs-Donnan equation. Can I get an okay from all of you if you've understood it, so that I can move ahead? Okay. ठीक है? Chalo, that's heartening that you've understood it. Okay. Micropuncture is not, you do not Hyderabad, you do not need ATP, because it's simply by a flow of lipids which is from the side of the puncture, right? Vishakhapatnam, Donnan equation not for sodium? Yes. Why not for sodium? It is not applicable for sodium because sodium, please remember, is not a diffusible ion. Have you understood? It is not a diffusible ion. The cell membrane is not permeable to sodium at rest. Have you understood? So we will not be able to apply this effect on sodium. What diffusible? Remember I said it is diffusible ions. Diffusible ions are potassium and chloride. Okay? Chalo. Okay, next let's go on to what do we understand by Nernst equation. Merit, pinocytosis is for क्या Gorakhpur, repeat the concept. Donnan effect, two conditions, semi-permeable membrane, presence of proteins on one side. It results in an unequal distribution of diffusible ions at equilibrium. This is very simply the Donnan effect. Hardly anything. Semi-permeable membrane, presence of proteins, unequal distribution of ions at equilibrium. Gorakhpur. And this distribution of ions at equilibrium, there is a mathematical relationship. That is ratio of K plus in X over K plus in Y is equal to Cl minus in Y over Cl minus in X. That means if I cross multiply, I get the product of diffusible ions on one side equal to the product of diffusible ions on the other side. Yes? And Gorakhpur, where do I see the Donnan effect? It is intracellular and extracellular compartments, बीच में एक semi-permeable membrane है, and intravascular and extravascular compartments, बीच में again एक semi-permeable membrane है और membrane के एक side पर proteins है. That is very simply your Donnan effect. चलिए, the next one is the Nernst equation. Nernst equation. Now what is the Nernst equation? बेटा जरा देखो, गड़बड़ हो गया. नहीं Debrugar, they're not freely permeable. I'll talk about permeability of potassium and chloride a little later. Just give me 2 minutes. बोल, नहीं हुआ बेटा, ठीक हो गया? नहीं हो रहा. ऑनलाइन राइटिंग करो. हो गया हो गया हो गया, मैं कर लेती हूँ. हाँ, अब हो गया. Nernst equation. Now what is this Nernst equation is? See, the Nernst equation, now for instance, let me try and first explain this to you, then we'll discuss the Nernst equation. Now see, you know that inside the cell, you have proteins which are negatively charged. They are impermeant and negatively charged. Right? Inside the cell, we have the presence of proteins which are impermeant and negatively charged. Impermeant means they cannot diffuse across the cell membrane, so they are present inside the cell. Right? Now, we also know that sodium is in a higher concentration outside the cell, less inside the cell, right? Or for example, let's take the example of potassium. Again, proteins inside, negatively charged. Potassium is more inside the cell and less outside. You know there's a gradient for potassium, yes? Now, for example, if, please understand there is a big if here. If the cell membrane becomes freely permeable to potassium, what will happen? Potassium will go from inside to outside the cell, higher to lower concentration. But proteins will try to pull it back. So there will come a point where the movement of potassium will stop. And that is called the point of equilibrium. Have you got it? See, I said there is more potassium inside the cell, less outside. If the cell membrane becomes freely permeable to potassium, potassium will go from inside to outside the cell. But at one point of time, the movement of potassium will stop because protein is trying to pull it back. Right? Right? At this point, this is known as the point of equilibrium. Now, what is the potential difference due to movement of the potassium, or what is the potential difference due to diffusion of potassium, also known as the diffusion potential of potassium? This will be known as the Nernst potential for potassium. Right? Similarly, if the cell membrane becomes freely permeable to sodium, now again sodium will come from outside to inside the cell, and at the point where the movement of sodium stops, that is known as equilibrium, and the potential difference at that point is known as the Nernst potential or the equilibrium potential of sodium. Right? Or let's take the example of chloride, for instance. Again, you've got proteins here. We've got more chloride outside the cell as compared to inside the cell. Now, chloride will move from outside to inside. That is, if the cell membrane becomes freely permeable, chloride will move from outside to inside till equilibrium is established. And the potential difference at that point is known as the Nernst potential for chloride or the equilibrium potential for chloride. So this is your background. Yes. So in other words, what is Nernst potential or the equilibrium potential? Or what does Nernst equation gives us? Nernst equation gives us the magnitude of magnitude of potential difference of an ion at equilibrium, provided cell membrane is freely permeable to that ion. This is a precondition. Whenever I want to calculate the Nernst potential, the Nernst potential, magnitude of potential difference of an ion at equilibrium, provided cell membrane is freely permeable to that ion. Right? So this is your magnitude of potential difference of an ion at equilibrium, provided cell membrane is freely, this is the precondition. Cell membrane has to be freely permeable to that ion. Right? Cell membrane has to be freely permeable to that ion. Now, Vishakhapatnam has asked me an interesting question. Why is sodium more outside the cell? See, please remember, ECF, if you look at evolution, ECF is, cell or biological, the evolution is believed to have started from the sea, right? And we find that the ECF is closer in composition to the C. C is sodium rich, right? So ECF is a sodium rich, ECF is sodium rich, whereas ICF is poor in sodium, right? So it is not that there is, why is that? This is how ECF is a sodium rich area or sodium rich fluid as compared to the ICF, right? This is sort of linked back to evolution, right? So this is your magnitude of potential difference of an ion at equilibrium, provided, like I said, what does Nernst equation give us? It gives us the magnitude of potential difference of an ion at equilibrium, sometimes also called equilibrium potential, provided cell membrane is freely permeable. So this is the precondition. Cell membrane has to be freely permeable to that ion. So if I want to calculate, now let us see what is the Nernst potential for each of these ions. Now the equilibrium potential for chloride. Equilibrium potential for chloride in millivolts. This is 61.5 log of chloride inside over chloride outside. That means I have to take into consideration the gradient for chloride while calculating the potential difference. Because please remember, The cell membrane in this situation, for Nernst equation, for equilibrium potential, cell membrane is freely permeable to chloride. So the only thing which is going to determine the potential is the gradient, right? So 61.5 log of chloride inside over outside. If I substitute the values, I get a value of minus 70 millivolts for chloride. Equilibrium potential for chloride is minus 70 millivolts. Equilibrium potential for chloride is minus 70 millivolts, right? Equilibrium potential for potassium. This is 61.5 log of potassium outside over potassium inside. Potassium outside over potassium inside. Again, now for a positively charged ion, please remember this. For chloride, it is inside over outside. For potassium, which is a positively charged ion, it reverses. It becomes outside over inside. Again, if I substitute the values, I get an equilibrium potential of potassium as minus 90 millivolts and or minus 94 millivolts, right? For sodium, equilibrium potential for sodium will be 61.5 log of sodium outside over sodium inside. So the equilibrium potential for sodium has a value of plus 61 millivolts. Plus 61 millivolts. So these are important values to remember. Sodium, chloride is minus 70, potassium is minus 90 or minus 94, and sodium is plus 61. Ludhiana, see this? It is applicable to all ions who have a concentration gradient, because like I said, the cell membrane has to be freely permeable to that ion. The condition is cell membrane has to be freely permeable to that ion, right? So we can use this Nernst equation to calculate the equilibrium potential for any ion, right? Cell membrane has to be freely permeable to that ion, yes? But of course, in reality, the cell membrane is a semi-permeable structure. It is not a freely permeable structure. So we have yet another equation which will now take into consideration not only the concentration gradient but also the cell membrane permeability, and this is known as the Goldman-Hodgkin-Katz equation. Goldman-Hodgkin-Katz equation. Now, what is this Goldman-Hodgkin-Katz equation? In this equation, I not only take into consideration the concentration gradient of the ions, I also take into consideration the cell membrane permeability for that ion. Cell membrane, not only concentration gradient, Mumbai, if both sodium 90 and 94 is given, then your better answer becomes minus 94, right? Minus 94. If you have an option question which says what is the equilibrium potential of potassium, is it minus 70, minus 80, minus 90, minus 100, then of course your answer is minus 90. But if it says minus 86, minus 90, minus 94, minus 98, then your better answer becomes minus 94. Meerat, what is your question? How protein equilibrates sodium as it attracts? Equilibration क्यों नहीं होगा? Sodium is a positively charged ion, right? And proteins are also proteins are negatively charged. So they will attract. Now cell membrane is freely permeable to sodium. So sodium will come from outside to inside, and proteins will allow that. But at any given point of time, the movement of sodium has to stop, isn't it? Because there is a concentration gradient. Now it cannot continue indefinitely, right? It cannot continue indefinitely, and that is because, like I said, because of the concentration gradient, right? Okay. Now, Goldman-Hodgkin-Katz equation. Okay. Allahabad, Bilaspur. Okay, fine. I'll do it in the break. Okay, Goldman-Hodgkin-Katz equation, which is, like I said, it depends on concentration gradient as well as the cell membrane permeability. Now, Goldman-Hodgkin-Katz equation, it is also known as the constant field equation. This is also known as the constant field equation. And like I said, this takes into consideration not only the concentration gradient but also the cell membrane permeability. Now, this gives us the value of resting membrane potential in millivolts. And this says resting membrane potential in millivolts is minus 61.5 log of. So this becomes slightly different from your Nernst equation, quite different from your Nernst equation. Nernst equation mein cell membrane permeability was the same for all the ions. Here we will take into consideration the cell membrane permeability for each of these three ions. This is minus 61.5 log of concentration of chloride. Chloride in Nernst equation I took inside over outside. Here it becomes outside over concentration of chloride inside into permeability of the membrane for chloride. Remember, I said concentration gradient as well as cell membrane permeability will be taken into consideration, right? Plus. Please remember, this is reversing from Nernst. Nernst was chloride inside over outside. This is chloride outside over inside. In Nernst, now potassium was outside over inside, but in Goldman-Hodgkin it becomes reverses again. So this is now concentration of potassium inside over potassium outside into permeability of the membrane for potassium into permeability of the membrane for potassium. Plus. ठीक है? माने अगर आप याद रख लें कि chloride in Nernst equation is inside over outside. For positive charged, it reverses in Nernst, but in Goldman-Hodgkin, it is chloride becomes outside over outside inside, and for positive charges, it again reverses, right? Plus concentration of sodium inside over sodium outside into permeability of the membrane for sodium into permeability of the membrane for sodium. So this is your complete equation, right? Now we know that the permeability of the cell membrane for potassium at rest is much more than the permeability for chloride, which is only slightly more permeable than sodium. In fact, the sodium ka permeability is almost zero. Sodium ka permeability is almost zero. O stands for outside Bareilly, right? This is sodium ka permeability, cell membrane is almost impermeable to sodium. Now, almost, I haven't said, remember I told you there is slight leakage of sodium, so but we'll take it as zero. So anything multiplied by zero is zero. So that means, does sodium contribute to the resting membrane potential? No. Why? Though there is a gradient for sodium, sodium is more outside, less inside, more in the ECF, less in the ICF. But the cell membrane is not permeable to sodium, so sodium does not contribute to the resting membrane potential. Therefore, which ion now contributes the maximum to? This is a question here. Which ion contributes the maximum to resting membrane potential? Which ion contributes maximum to resting membrane potential? And your answer becomes potassium. Why potassium? Gradient तो दोनों के लिए है, potassium के लिए भी और chloride के लिए, लेकिन which is the one which is contributing maximum is potassium, because the permeability of the cell membrane is maximum for Potassium. In fact, answer this question. If I increase the extracellular sodium, what will happen to resting membrane potential? Will it become more negative? Will it become less negative? Or will it remain the same? Bolo. There will be no change because sodium has nothing to do with resting membrane potential. Have you got this? Right? So this is your resting membrane potential and the Goldman-Hodgkin-Katz equation. We will take into consideration both concentration as well as cell membrane permeability. Right? So this is, like I said, your Goldman-Hodgkin-Katz equation. Any questions thus far? Especially since we are talking of slightly difficult, these are slightly difficult topics, so I thought. Now, Dibrugarh, this is not for us to say why is it reversed, because this is the way the equation is. I was only trying to help you in, I was trying to make you sort of help you remember it, right? But this is the way the equation has been formulated. So we cannot question it why. Otherwise, we need to go into too many details, which is outside the purview, right? Anything else? Anything else from anybody as far as the Goldman-Hodgkin-Katz equation and the Nernst equation is concerned? Again, we cannot, it is not for us to say why is this over here. This is the way the equation has been derived, right? So we cannot discuss why this is the minus sign here. Hyderabad, abhi I'm just coming to that. Anything else? As up till now, anything? Acha, you're trying to say, okay, because of the minus sign, this has got reversed. Is this applicable if you have a log in between? Yes, I do not know whether it is applicable if you have log in between. Okay. What determines the differential permeability of sodium, potassium and chloride? See, please remember, when I say at rest, ions cannot cross the cell membrane. They're not lipid soluble. But there have to be some channels which are open at rest. That is what determines the permeability of these particular ions, right? It determines the permeability of these ions, right? Kolhapur, I'm not taking a break right now. I need 10 more minutes. I want to finish this topic and then we will go on. Okay. Now, like I said, let's see the we just discussed that if there is increase in sodium, there is no increase or decrease in sodium, there is no change in resting membrane potential. Okay? Lekin if there is increase or decrease in potassium, then the resting membrane potential will change. Right? So let's see what is going to be the change if there is increase or decrease in extracellular potassium. Yes? So let's see this. So to understand this, let's do a very basic. Let's revise our basics first. This is a cell at minus 70 millivolts. This is your resting membrane potential. Now supposing I change the potential of the cell to minus 80 millivolts. This is called an increase in potential or a decrease in potential. Jabalpur, just hang on for a minute. I will answer these questions. Just wait for some time, right? Is this an increase in potential or a decrease in potential? Please understand, the potential, all of you are wrong. This is not a potential, it is a potential difference. Mane kya? When I say it's minus 70 millivolts, it means that the potential is 70 millivolts. Negative sign is only telling you that inside is negative with respect to outside. Have you understood? There's no mathematical significance of this negative sign. Negative sign, it was, you remember, what is negative with respect to outside? Even if I have 3 positive charges outside, 2 inside, inside is negative with respect to outside. So when the potential changes from minus 70 to minus 80 millivolts, when the potential changes from minus 70 to minus 80 millivolts, this is called an increase in potential. Increase in potential, or the cell has been hyperpolarized. There is a hyperpolarization. There is increase in potential or a increased polarization. And when a cell has been hyperpolarized, this is known, this causes a decrease in excitation, excitability. Right? Similarly, if the potential changes from minus 70 to minus 60 millivolts, this is a decrease in potential or a depolarization, right? And increase in excitability, right? Increase in excitability. Have you understood this concept, right? This is the concept behind increase in potential, decrease in potential. Like the way Haldwani you've written, then increase. Pehle decrease, then increase. Okay. So this is increase in potential and a decrease in excitability, decrease in potential, increase in excitability. So let's see what happens if there is a hypokalemia. Let's try and understand it. Now we've said that inside the potassium is 140, outside is 4. Yes? Inside, Mysore, I haven't done much. This is minus 70 to minus 80. This is known as an increase in potential, hence the name hyperpolarization, right? And whenever the cells are hyperpolarized, there is a decrease in excitability, right? That is what I was trying to tell you. Minus 70 to minus 80. Whenever you change the potential from minus 70 to minus 80, it is an increase in potential. Because here remember 70 to 80 millivolts. Negative sign ka significance ye kya hai? Ki it is only telling you the direction. It is only telling you that inside is negative with respect to outside. Now let's take the example of hypokalemia. Inside potassium is 140, outside is 4. The gradient is 136, right? If the outside potassium decreases to 2, now the gradient has become 140 minus 2, which is 138. Mane, if there is hypokalemia, the gradient increases. If gradient increases, this will result in an increase in diffusion potential of potassium. And if the diffusion potential increases, mane, increase in potential, what did I tell you just now? If increase in potential is known as, now the cells will become hyperpolarized. It results in hyperpolarization. If there is a decrease in extracellular potassium, there is increase in gradient. Gradient is no longer 136, it is 138. This causes increase in diffusion potential of potassium or a hyperpolarization. So instead of the cells being at minus 70, maybe minus 75 millivolts. Yes, the potential has increased. Excitability decreases. See, what is the most common complaint, most common symptom of hypokalemia? A muscle weakness. Hypokalemia causes muscle weakness. Where on ECG, what do I find? On ECG, what I see is, on ECG, there is a prolonged QRS. Prolonged QRS, a widened QRS, because the excitability is reduced. Excitability is reduced. So this is what you find on hypokalemia. Next, let's try and do what happens with hyperkalemia. Let's see hyperkalemia. Now, hyperkalemia is the supposing, like I said, 140 here, 4 here, gradient is 136. Supposing I double it here, the gradient now becomes 140 minus 8, which is 132. So the gradient there is a decrease in gradient, which causes a decrease in potential. And decrease in potential is known as depolarization. So what happens in depolarization? Increased excitability, right? But unfortunately, hyperkalemia is not very simple to understand. There is a little bit of a complication here, and that is, see, not only are the cells depolarized, yes, where increased excitability. In fact, arrhythmias are a common feature. Arrhythmias are commonly seen in hyperkalemia. That is because the excitability is altered, it increases. But what is complicating the picture over here? The cells now go into a state of persistent depolarization. The cells have gone into a state of persistent depolarization, and this persistent depolarization in fact reduces excitability. It reduces excitability, right? Persistent depolarization which reduces excitability. Are we clear? Right? Why does persistent depolarization reduce excitability? You have to give me half an hour's time, 1 hour's time. I will do something else and I will come back to this point. But I need to explain something else to you before I can explain persistent depolarization state. Okay? So you have to give me some time and I will come back to this point. But please understand, whether it is a decrease in potassium or an increase in serum potassium levels, both will eventually produce a decrease in excitability. Clear? Now, also on ECG, in the case of hyperkalemia, we see what are known as tall tented T waves. Tall tented T waves are seen. T waves look like this in hyperkalemia. Tall tented T waves. Now, what is the exact reason for this tall tented T waves? We do not know. No book has been able to explain why are they tall tented T waves. Bas itna kaha hai, this is because of an abnormal repolarization. What is the abnormality? Difficult to say. So please remember, hyperkalemia, what has happened? Hyperkalemia, there is an now decreased gradient, decreased potential, cell is depolarized, excitability increases, arrhythmias are seen. But the cells have gone into a persistent depolarization and which now produces a decrease in excitability. Right? Decrease in excitability. Are we okay with that? Eventually both hypo as well as hyperkalemia will produce a decrease in excitability. Right? Okay. Now I'll ask you a question and then I'll go in for a break. And the question is, in hyperkalemia, heart stops in diastole या systole. And let me see which center can answer this question. This is थोड़ा सा टेढ़ा question. Jabalpur is the only one who's got this right. No, so has Haldwani. Okay, great. See this. See what has happened in hyperkalemia. Remember I said whether it is hypo or hyperkalemia, there is a decrease in excitability. Vishakhapatnam also. So also Bilaspur. Okay, great. So there is a increase whenever there is increase in serum potassium levels, I told you the cells go into a persistent depolarization state which decreases excitability. देखो हमेशा electrical activity will be followed by contractile activity. Electrical activity will be followed by contraction. अब ये जो cells है, in the case of hyperkalemia, now the excitability is reduced. Yes, electrical activity is less. So will I be able to get contraction? Contractile activity? No. Have you got my point? Reduced pehle electrical activity followed by contractile activity. But if the electrical activity itself, now it is difficult to excite these cells. So electrical activity itself is reduced. So it will not be followed by contractile activity. In fact, what happens in hyperkalemia is heart starts dilating. It becomes flaccid. It starts dilating and eventually the heart stops in diastole. In hypercalcemia, heart stops in systole, but in hyperkalemia, it stops in diastole. Clear? think about this. I'll take a break for about 10-15 minutes, and then we'll start off again, and let's see if you can just go over what we've just discussed. Hypokalemia. There is hypokalemia. There is a increase in gradient. More will be the diffusion potential. More will be, or the cells get hyperpolarized. Excitability reduces. Hyperkalemia, decrease in gradient. Depolarization, excitability should increase. But in fact, because of persistent depolarization, the excitability reduces. Okay? In fact, in hyperkalemia also, Gorakhpur, you will be able to find widened QRS in hyperkalemia. Okay? Now, class is till what time? We have, our class is scheduled till 9 o'clock. So, 9. Okay? So, I'll take a break now. Okay. हाइपोकिलीमिया मैंने बताया ना, ईसीजी बरेली, आई टोल्ड यू हाइपोकिलीमिया में एक वाइडेंड क्यूआरएस है. दोनों में मैं इवेंचुअली यही तो बोल रही हूं कि हाइपो हो या हाइपर हो, इवेंचुअली बोथ आर प्रोड्यूसिंग अ डिक्रीज इन एक्साइटेबिलिटी. बेलगाम रुक जाओ, अभी आई हैव टू डिस्कस दिस सेट ऑफ क्वेश्चंस विद यू. डोंट वरी, आई विल डू इट विद यू. I have to discuss these, which is the resting membrane potential is close to, equal to, due to which ion. I have to discuss these set of. All right. Okay, so let's resume from where we left, where we finished last before the break. This was concerned with potassium, when we said that if there is a hypokalemia, there is decrease in excitability. If it is a hyperkalemia, eventually it produces a decrease in excitability. So this was hypo and hyperkalemia. Next, let's have a look at what is the effect of see, because you must understand, Mumbai, your question, why does correction of hyponatremia affect only the brain cells? See, please remember, the brain cells are the one which are enclosed in a bony cage, skull, right? So whenever there is a decrease, or especially whenever there's an increase in volume, right? Increase in volume, it will now affect the brain cells much more than the others. Have you understood? So the effect on brain cells will be much more because of the fact that it is enclosed in a bony cage, right? So that is why, and this is the one which has got disastrous consequences also. Have you got my point? Increase or decrease in volume of the brain cells has got near disastrous consequences. So we are only, so it is these cells which show osmotic adaptation, right? The brain cells. Okay? All right, so I don't think there are any other questions. Let me take on the next part, and that is, let us see what is the effect of Mysore. Just give me a little time. There is neuron which I'm going to be doing. I'll be doing it all that there, right? Just give me a little time. Now, what is the effect of hypocalcemia? What is the effect of hypocalcemia? Now, hypocalcemia causes what is known as, it causes an increase in neuronal as well as muscular excitability. Hypocalcemia causes an increase in neuronal and muscular excitability. And this is, of course, you know that, this is tetany. So how does hypocalcemia increase the neuronal and muscular excitability? Please remember, calcium has nothing to do with resting membrane potential. And the reason for that is, calcium has nothing to do with resting membrane potential because the cell membrane is not permeable to calcium at rest. Exactly the same reason as sodium. Though there is a gradient for calcium, we know that calcium is more outside the cells and less inside the cells, but there is no effect of calcium on resting membrane potential, primarily because the cell is not permeable to calcium. The cell membrane is not permeable to calcium at rest. Oh God, what is this Mumbai long question? Oh, Mumbai, I will sort out this answer when I do kidney with you. You will get an answer to your question in kidney. Okay? Not to worry. Sodium potassium ATPase, how does it decrease sodium potassium ATPase and how does it produce natriuresis? Right? We will do this when I go to kidney. I'll remember to point it out to you. Okay, so Vishakhapatnam. Okay, so this is your, let's see what is the effect of calcium. Now, please remember, now whenever we talk in terms of channels, now this is a voltage gated sodium channel. This is a voltage gated sodium channel. This is ECF and this is ICF. This voltage gated sodium channel, this is lined by negative charge, right? It has got two gates, one towards the outside, one towards the inside. And please remember, whenever a channel is open, that particular ion will always come from higher to lower concentration. So sodium always comes from, whenever this channel opens up, sodium will come from outside to inside. Now, what is the role of calcium here? Calcium now is present on the mouth of this channel. Calcium is a positive charge, positive ion. So it is present on the mouth of this channel like a chowkidar. Right? And whenever there's a chowkidar outside a building, there is always a regulated entry. So this calcium has what is known as, calcium causes a regulated entry of sodium from ECF to ICF. Right? So calcium is said to have a membrane stabilizing action. There is a membrane stabilizing action of calcium. But whenever there is a hypocalcemia, this membrane stabilizing action of calcium is lost. So what happens now? Now there is an unregulated and free entry of sodium from outside to inside, and that increases the excitability. So there is an increase in neuronal and muscular excitability. So why is there, though calcium has nothing to do with resting membrane potential, but there is increased neuronal and muscular excitability because this membrane stabilizing action of calcium is lost, right? So this is what is responsible for tetany. Now, Kolhapur, you have a question. It says in Nernst equation for sodium shouldn't what? It should be inside. What? Shouldn't in numerator it should be inside? No. I remember I told you Nernst equation for chloride is 61.5 log of chloride inside over chloride outside. Like for positively charged ions, it's outside over inside, right? Outside over inside. So for sodium, it becomes 61.5 log of sodium outside over sodium inside. It reverses. Okay. Now this is as far as your now as far as tetany, Rohtak, just have a look at tetany. Why did I say tetany? See, what is the action of calcium? See, whenever the voltage gated sodium channel opens up, sodium comes from outside to inside. Calcium has a membrane stabilizing action. See, the easier way to understand this is calcium is C for calcium, C for chowkidar. Chowkidar outside a building. Regulated entry of sodium. Chowkidar goes on chutti, that is hypocalcemia. Now there is a unregulated and free entry of sodium into the cell, which causes easy depolarization, and therefore this is what is responsible for the increase in neuronal and muscular excitability, right? So this is as far as your hypocalcemic tetany is concerned, right? Next, the next concept in general physiology which I need to take up with you, and that is, what are the Starling's forces at tissue level? Starling's forces in a tissue capillary. Starling's forces in a tissue capillary. Now this is a tissue capillary here. Now within a tissue capillary there is a push force. And what is a push force? Push force is the hydrostatic force or the hydrostatic pressure. Push mein H hai, H for hydro. This means this is the force which pushes the fluid out of the capillary into the surrounding area, into the interstitium. This is your push force or the hydrostatic force. Then there is a pull force, and the pull force is the colloid osmotic pressure. Colloid osmotic pressure, double L in colloid, double L in pull force. This pulls the fluid back inside. So you have a hydrostatic pressure, which is the push force, and the colloid osmotic pressure, which is the pull force, right? A push and a pull force, right? Similarly, the interstitial fluid also has a push force, also has a pull force. And the push force is the hydrostatic pressure of the interstitial fluid, and the pull force is the colloid osmotic pressure of the interstitial fluid, right? So these are your two push forces and pull forces. Push force, capillary hydrostatic pressure. This is in fact the largest one. This is the largest one, right? This is your push force here. Opposing the movement of fluid is this colloid osmotic pressure, which is the pull force. Similarly, the interstitial fluid also has a push force and a pull force. Of course, we know that the colloid osmotic pressure of the interstitial fluid is 0. And why is it 0? Because obviously there are no proteins which are present in the interstitial fluid. No proteins which are present, therefore the colloid osmotic pressure is 0. That means now what is my net pressure? Net pressure becomes, this is PC minus pi C minus Pi. Net pressure is PC minus pi C. Why is, if I take PC as positive, pi C is negative, Pi is negative. So it's PC minus pi C minus Pi. In other words, the rate of tissue fluid formation is directly proportional to the net force. It is directly proportional to the net force. That means this is directly proportional to PC minus pi C minus Pi. I hope you've understood why are we saying minus pi C. The reason is if PC is positive, pi C opposes it. So pi C is a negative, Pi is also a negative. So it's PC minus pi C minus Pi, and the rate of tissue fluid formation is directly proportional to this PC minus pi C minus Pi. I want to remove the proportionality sign, bring in an equal to sign. I have to multiply it by a constant. Constant is Kf into PC minus pi C minus Pi. And what is Kf? Kf is permeability into surface area. Permeability into surface area, right? This is the constant. This is also known as in fact the ultrafiltration constant. Ultrafiltration constant. This is permeability into surface area. Now the factors which affect the filtration of fluid or the tissue fluid formation is number 1, permeability. More permeable the capillary, more will be the tissue fluid formation. It also depends upon surface area, right? Number 3, it depends upon the capillary hydrostatic pressure. More the capillary hydrostatic pressure, more the tissue fluid formation. It depends upon colloid osmotic pressure of the capillary. Colloid osmotic pressure of the capillary, now the pull force, this is hypoalbuminemia. Colloid osmotic pressure of the capillary decreases. Hydrostatic pressure of the interstitial fluid. Hydrostatic pressure of the interstitial fluid. These are your 5 factors which affect the tissue fluid formation, right? More the hydrostatic pressure in the capillary, more is the tissue fluid formation. Hypoalbuminemia hai, pull force kam hai, more tissue fluid formation, right? So these are your factors affecting it. 2 important questions here. Organ with maximum PC. Organ with maximum PC. This is organ with maximum PC is the kidney, and organ with maximum with maximum KF is also the kidney. Organ with maximum KF is also the kidney. Maximum PC, kidney. Organ with maximum KF is also the kidney. But if your question says, which is the most permissible capillary? Which is the most permissible capillary? Is it the capillary in the liver or in the kidney? Then my answer is liver. Because please remember, the liver capillaries, the hepatic, you have sinusoids. These are sinusoidal. Sinusoidal means there are large gaps between the endothelial cells. Whereas in the kidney, it is a fenestrated capillary. So most permissible becomes liver. But if the question says which is the organ with the maximum KF, KF will become the kidney, because please remember, in KF you're not only talking of permeability, you're also talking of surface area. So organ with maximum KF is the kidney, and organ with maximum PC is also the kidney. This is where we come to the end of our chapter on general physiology. Let's take on the next one, our next chapter, and which is neuron. Now herein I will address all your concerns about RMP and this, that and the other. So let's do that now. Now, before I take on the resting membrane potential of different cells, let me just tell you, there was a question which was asked in DNB this time, which are the different types of channels, right? They are two subunits. Yes, Belgaum, yes. PC is capillary hydrostatic pressure, right? So neuron, let's take on firstly, what are the different types of channels which are present? Now, chloride channels in animals and bacteria, these are dimers. Chloride channels in animals and bacteria are dimers, right? Chloride channel. Sodium channels, including the epithelial sodium channels, these are trimers. Sodium channel is a trimer. Potassium channel is a tetramer. 4 subunits. And what are these 4 subunits? How does it look like? This is what a potassium channel looks like. 4 subunits. Aquaporin, water channel. This is also a tetramer, but here it is slightly different. Here it has got, aquaporin is a tetramer. It has got 4 subunits, and each 4 subunits have got a pore each. Aquaporin, tetramer. Chloride channel in humans. Chloride channels in humans is a pentamer. Acetylcholine and ligand gated channels. These are also pentamers. Right? So you've got the chloride channel pentamer, acetylcholine and ligand gated channels are also pentamer. So this is a complete list here. Chloride channel in animals and humans, dimers. Sodium channels, including epithelial sodium channels, trimers. Potassium channels are tetramers. Aquaporins are again tetramers. Chloride channels are pentamers. Acetylcholine and ligand gated channels are pentamers. Next, let's see what is the RMP of different cells. Let's see what is the RMP of different cells. Now, resting membrane potential we have just discussed a little while back. It is due to potassium with a small contribution from the sodium potassium pump. Now, RMP of most neurons. RMP of most neurons is minus 70 millivolts. For spinal motor neurons, it is minus 90 millivolts. Most neurons is minus 70, spinal motor neurons is minus 90. Skeletal muscle fibers. skeletal muscle fibers is minus 90 millivolts. Ventricular muscle fibers, again minus 90 millivolts. Smooth muscle cells, minus 50 to minus 60 millivolts. Pacemaker cells, minus 50 to minus 60 millivolts. Inner hair cells of the cochlea, minus 60 millivolts. Rods and cones, minus 40 millivolts. RBCs, minus 10 millivolts. So these are complete list of the RMP of different cells. Most neurons minus 70, spinal motor neurons minus 90, skeletal muscle fibers minus 90, ventricular muscle fibers minus 90, smooth muscle cells minus 50 to minus 60, pacemaker cells minus 50 to minus 60, inner hair cells of the cochlea minus 60, rods and cones minus 40, RBCs minus 10. So this is your complete list of RMP. Next come a series of questions. Now I've just told you that the RMP of most neurons is minus 70 millivolts. So now there are three questions which I'm going to ask you, and this is RMP of neurons. RMP of neurons is due to, is it potassium or chloride? Second question, RMP of neurons is close to equilibrium potential of potassium or chloride, and RMP of neurons is equal to equilibrium potential of potassium or chloride. Okay? These are the three sets of questions. Rohtak, quickly, please copy this down. Right? Now, there are three set of questions which I'm asking you related to resting membrane potential. The first one I said is, RMP of neurons is due to. Now, due to is very simple. We've discussed it already. This is potassium. And why potassium? Because we said the cell membrane is maximally permeable to potassium at rest. Now, Jabalpur and Vishakhapatnam, you've answered chloride, and so has Dehradun. Please, there needs to be a change in your answer to the second question. And the second question, now the change is, now there is a reference which is given to this answer, my question number 2. The reference is Genong, 24th edition, page number 93. Now, this says very clearly, the resting membrane potential of neurons, it is due to potassium and it is close to the equilibrium potential of potassium. Reference, I've already quoted the reference to you. You can have a look in the 24th edition of Genong, where this has been very, very clearly mentioned that RMP is close to equilibrium potential of potassium. And this has got a reason behind it also. See, after all, what is the RMP due to? RMP is because of the movement of potassium from inside to outside the cell. Why? Because the cell membrane is maximally permeable, almost freely permeable to potassium. And if you remember, for equilibrium potential, when I discussed Nernst equation with you, what was the precondition that I spoke of? I said that the cell membrane has to be freely permeable to potassium. Now, at rest, the cell membrane is almost freely permeable to potassium. So that means now the RMP will be due to potassium and as close to the equilibrium potential of potassium as possible. See, everything likes to achieve its state of equilibrium. Potassium also. Now the cell membrane is freely permeable. Potassium moves from inside to outside the cell. But if the question says RMP is equal to the equilibrium potential of, then we will say chloride numerically it is equal to the equilibrium potential of chloride. But for your answer question number 2, you need to change this, because like I said, the earlier editions of Genong did not have this reference. Now they have very clearly mentioned, though the resting membrane potential, this is a direct lift from what is given in Genong 24th edition, though the resting membrane potential is equal to the equilibrium potential of chloride, it is close to, it is due to and close to the equilibrium potential of potassium. So this is your, these set of questions you will have to, especially the second one, you will have to change it from what is given in your guidebooks, because there is a solid reference for this, and and then it makes a lot of sense also, isn't it? Because after all, it is potassium which is responsible for the resting membrane potential. So the resting membrane potential should be close to the equilibrium potential of potassium. Chloride has nothing to do with the resting membrane potential, isn't it? It's due to potassium, and the RMP will be close to the equilibrium potential of potassium, right? But equal to, numerically equal to the equilibrium potential of chloride, right? Now, again, if the questions say RMP of large motor neurons, now I'm changing it slightly, RMP of large motor neurons, and large motor neurons have an RMP of minus 90 millivolts. RMP of minus 90 millivolts. Now, RMP of large motor neurons is due to potassium or chloride, then your answer becomes potassium. Close to equilibrium potential of, again, potassium, and in this case equal to equilibrium potential of, in this case it will still be potassium, because RMP of large motor neurons is minus 90 millivolts. This is the RMP of your large motor neurons due to potassium, close to equilibrium potential of potassium and equal to the equilibrium potential of potassium. But if it says only neurons, then you have to go with due to potassium, close to equilibrium potential of potassium and equal to the equilibrium potential of chloride. Right. Next, let's see. When I talk in terms of the resting membrane potential, yes, this is your resting membrane potential. Now here, let's have a look at what are local potentials and what are action potentials. So let's try and understand this. The next is, what are local potentials and what are action potentials, right? Local potentials and action potentials. Now here is a neuron at a resting membrane potential of minus 70 millivolts. I give a small electrical stimulus, and this now causes the opening of some voltage gated sodium channels. And whenever there is opening of a channel, I have already discussed it with you, there is movement of that ion from outside to inside, or from higher to lower concentration. In this case, it is a sodium channel which has opened. So sodium comes from outside to inside. And when positive charge enters into the cell, the potential of the cell now becomes minus 69, 68, 67, 66, and maybe reaches minus 65 millivolts. Now the sodium channels close and the potential of the cell comes back to the resting membrane potential of minus 70 millivolts. Therefore, this potential is a local potential and the stimulus is a sub-threshold stimulus. Now let's take the second situation. Again, cell is at minus 70 millivolts. Now this time I give a stimulus which is larger than the first one, stronger than the first one. You have opening of more voltage gated sodium channels, more influx of sodium. Potential changes from minus 70, minus 65, 64 and it reaches minus 60 millivolts. Now the voltage gated sodium channels close and now it goes back to resting membrane potential. This is also a local potential and the stimulus will also be a sub-threshold stimulus. तीसरी सिचुएशन देखिए, फिर से -70 millivolts पर है. Now I give a stimulus which is larger than the first two. Larger than the first two. Now the more voltage gated sodium channels open, more influx of sodium, potential changes from -70, -65, -60, -55 millivolts. -55 millivolts. Now -55 millivolts is known as the firing level. This is known as the firing level. And what happens in firing level? Now there is a sudden opening of sodium channels, and this now causes a huge influx of sodium. Sudden opening of sodium channels, huge influx of sodium, and you get an action potential. You get an action potential. So this is your action potential. So this is what is, this stimulus will therefore be known as a threshold stimulus. Therefore, let's see the differences between local potentials and action potentials. Let's see that. Number one, local potentials are produced by sub-threshold stimuli. This is by sub-threshold stimuli. These are local changes produced by sub-threshold stimuli. Action potentials are by threshold or supra-threshold stimuli. Threshold or supra-threshold stimuli. Right? Next, this is a graded response. Local potentials are graded responses. Why graded responses? Graded response माने छोटा stimulus छोटा change, बड़ा stimulus बड़ा change. So this is a graded response. Whereas action potentials are all or none responses. All or none responses. Now local potentials, these are decremental. Decremental माने the magnitude of this potential change will decrease over time and space. Decremental responses. Whereas action potentials, they travel from one part of the neuron to another without any decrement. Without any decrement. This is a decremental response, and that is, it travels without any decrement. Okay? Next, action potentials are self-propagated responses. These are obviously not self-propagated. Okay? So these are the important differences. Subthreshold stimulus, graded responses, decremental, not self-propagated. This is by threshold or supra-threshold stimulus. All or none law, travel without decrement, and self-propagated responses. Now, local potentials can be depolarizing or hyperpolarizing. A depolarizing local potential is an EPSP, excitatory postsynaptic potential. A hyperpolarizing local potential is an IPSP, inhibitory postsynaptic potential. Depolarizing or hyperpolarizing, whereas an action potential is always depolarizing. Always depolarizing. Okay? Next, action potential will be followed by some action. Something will happen. It will be followed by some action. Whereas a local potential may or may not be followed by some action. May or may not be followed by some action. Next difference. Local potentials can be summated. Summation is possible. But action potentials, no summation. What is summation? Summation means addition. Now there are two types of summation, right? So we've done this. Now look at the differences. Subthreshold stimuli, graded responses, decremental, not self-propagated. They could be depolarizing or hyperpolarizing. Depolarizing local potential is EPSP, hyperpolarizing is IPSP. They may or may not be followed by some action, because action potential is always followed by something will happen after an action potential. Either a muscle will contract or a gland will secrete, something will happen. And here I said summation is possible, which is not seen in action potentials. So let's see what are the types of summation. Now the types of summation are two. There is a spatial summation and there is a temporal summation, spatial as well as temporal summation. Now what is spatial summation? Spatial summation mane, just say this is a neuron here. If I give one subthreshold stimulus, I get a local change. There is a local change. But if I give a number of subthreshold stimuli simultaneously, if I give a number of subthreshold stimuli simultaneously, I get an action potential. This is spatial summation, right? In this case, it is a number of subthreshold stimuli given simultaneously. Number of subthreshold stimuli given simultaneously. This produces an action potential. Number of subthreshold stimuli given at the same time produces an action potential. Right? What is temporal summation? Spatial summation means over space. I gave these subthreshold stimuli, and these, when I give them simultaneously, they produced an action potential. So I called it a spatial summation. Right? In the case of temporal summation, see, when I give one subthreshold stimulus, a local potential only. लेकिन जब मैंने repeatedly एक के बाद एक दिया, then their effects are added over time. So that is called a temporal summation. What happens in a temporal summation? Now there is an increased frequency of subthreshold stimuli. There is an increased frequency of subthreshold stimuli, and these produce an action potential. Increased frequency of subthreshold stimuli which produce an action potential. This is known as a temporal summation. So you've got a spatial summation and a temporal summation, right? This will be seen in the case of local potentials only. The examples of local potentials, let's see, examples of local potentials. Two I've already told you. There was EPSP, excitatory postsynaptic potential, inhibitory postsynaptic potential, receptor potential, motor end plate potential, these are all examples of local potentials. EPSP, IPSP, receptor potential, motor end plate potential. Right? Now the kind of questions which have been asked from here, are, which of the following is true about local potentials? Which of the following is, or which of all of the following are true about local potentials except A, decremental responses? Yes. Produced by subthreshold stimuli? Yes. Graded electrogenesis? Yes. Self-propagated? No. So these are the kind of questions which have been asked. Again, I'll repeat this question. All of the following are features of local potentials except A, decremental responses? Yes. Second was graded electrogenesis? Yes. Produced by subthreshold stimuli? Yes. Self-propagated? No. Clear? So these are the kind of questions. Again, the same thing has been asked, same kind of a question. All of the following are features of action potential except. So again, you should be able to answer these questions if you know the differences. Okay? So this is local potentials and action potentials. Next, let's see what is the site of generation of an action potential. Site of generation of an action potential. Now see, when I look at a neuron, right? These are the dendrites here. It's a multipolar neuron. These are your dendrites here, right? Now this is called now let's see the different parts of this neuron. Now the dilated part of the cell body from which the axon arises is called the axon hillock. Now what is axon hillock? It is the dilated part of the cell body from where the axon arises. And this part of the axon, which is unmyelinated, initial unmyelinated part of the axon, is called the initial segment. Both of these areas are almost they're continuous with each other. Axon hillock is a part of the cell body जहां से axon arise करता है. Initial segment is the initial unmyelinated part of the axon. Okay? And this part, this is what is known as the soma dendritic zone. Soma dendritic zone, right? So these are your three major divisions of the neuron: soma dendritic zone, axon hillock, initial segment, and of course the axon. Now this soma dendritic zone, local potentials arise in the soma dendritic zone. This has been asked as a question last year. Local potentials आपको कहाँ दिखाई देंगे? Soma dendritic zone, axon hillock, initial segment, axon, commonly found in the soma dendritic zone. Whereas axon hillock and initial segment, what is the feature of these two areas is that they have a very high concentration of sodium channels per unit area. And because of this high concentration of sodium channels per unit area, these areas have a low threshold potential. There is a low threshold potential, very high concentration of sodium channels per unit area, and because of this, they have a low, that means these areas are easy to excite because they have a very high concentration of sodium channels per unit area. Now let's go on to the question. So this is a topic is very simple. There's hardly anything here. Yes, but let's try and do the questions which have come from here. My first question. Site of origin of the action potential. Site of origin of action potential in a spinal motor neuron is. Site of origin of an action potential in a spinal motor neuron is it the cell body? Is it the dendrites? Is it the axon hillock? Or is it the axon? Your answer becomes axon hillock. Yes, and makes a lot of sense. Why the axon hillock? Because it has a very high concentration of sodium channels per unit area. Clear? Next question. Same question is repeated, but the options now are cell body, dendrites, axon hillock, initial segment. Now my answer becomes initial segment. Out of the two, if I have to choose, If only one is given, then there's no problem. But if I have to choose between the two, then my better answer is initial segment, right? So site of generation of an action potential in a spinal motor neuron is initial segment. Okay? Now the next question is, why the initial segment? This was an Ames question which was asked. Why initial segment? A, is it because it has a very high concentration of sodium channels per unit area? Yeah, B, it has a low threshold potential. Bolo. A या B? But Dehradun, Bilaspur, Vishakhapatnam, why? What is this low threshold potential due to? Why is there a low threshold potential? It is because of this very high concentration. Of course, both the answers are right. There is nothing wrong with both the answers. But when I have to go into my exam, I have to mark only one. And what do? In this case, the low threshold potential is because of a very high concentration of sodium channels. So my slightly better answer becomes A. Very high concentration of sodium channel leads to a low threshold potential. So like I said, my better answer becomes A. Next question related to the same topic, and that is highest concentration of sodium channels. Highest concentration of sodium channels kahan par hai? Is it the axon hillock? Is it the initial segment? Or is it the nodes of Ranvier? Highest concentration of sodium channels is in the initial segment, axon hillock, or the nodes of Ranvier, and your answer in fact becomes the nodes of Ranvier. Please understand, when we were discussing the axon hillock and the initial segment, I told you that they have a very high concentration. I did not say highest concentration. Highest concentration is in fact in the nodes of Ranvier. Nodes of Ranvier will have the highest concentration. My next question. Action potential in a sensory neuron. Action potential in a sensory neuron arises in dendrite, cell body, axon hillock, initial segment, or the initial node of Ranvier. See, as far as the motor neuron was concerned, there was no problem. Motor neuron, we said axon hillock or initial segment. If both are given, then my answer is initial segment. But if it says in a sensory neuron, the action potential arises in fact in the initial node of Ranvier, the first node of Ranvier. And why does this happen? Let's try and understand this. Why is it that in a spinal motor neuron, it is in the initial segment, but why in a sensory neuron, it is the first node of Ranvier? Let's try and understand this. Allahabad, be careful. Sensory neuron, initial node of Ranvier. Motor neuron, initial segment. So let's try and understand this. Why is it motor neuron is the initial segment? See, motor neuron, look at this. Now this is a cross section of your spinal cord, right? This is the butterfly shaped gray matter here, spinal canal. This is the posterior root, dorsal root ganglion, anterior. Together they form the spinal nerve, right? Now your motor neuron arises from the anterior horn of the spinal cord. Motor neuron arises over here in the anterior horn of the spinal cord. Now this motor neuron now goes towards the muscles. Yes, this is also called the lower motor neuron or the spinal motor neuron or the A alpha motor neuron. Same thing. A alpha motor neuron or the lower motor neuron or the spinal motor neuron, or called the anterior horn cell. They are all the synonyms for the same neuron. This is the motor neuron which goes towards the muscle. Now the major tract which controls this is this one. This is the corticospinal tract. Corticospinal tract. This is your upper motor neuron. Now when upper motor neuron excites the lower motor neuron, now the impulses will be generated in the initial segment. Action potential is generated in the initial segment, and this action potential now jumps from node to node and goes towards the muscles. Action potential now jumps from node to node and goes towards the muscles. This is your A alpha motor neuron, lower motor neuron, spinal motor neuron, or the anterior horn cell. When the upper motor neuron stimulates the lower motor neuron, action potential is generated at the initial segment, and then this action potential jumps from node to node and reaches the muscles. So in motor neurons, the site of origin is the initial segment. Right? So there should be no problem with this one. Motor neuron, initial segment. Now let us see the sensory neuron. Now as far as the sensory neuron is concerned, let's see the organization. Again, cross section of the spinal cord. Gray matter. Posterior horn. Dorsal root ganglion. Now the DRG cell. DRG cell, this is the first order sensory neuron, dorsal root ganglion cell, and this is a pseudo unipolar neuron. Pseudo unipolar means it looks as though it has one process, but in fact it has two. One which goes towards the skin and the other which goes towards the spinal cord. This is your first order sensory neuron. First order sensory neuron. This is your pseudo unipolar neuron. Pseudo unipolar neuron, right? First order sensory neuron is your pseudo unipolar neuron. This is the skin here. This first order sensory neuron goes towards the skin, the peripheral process, combines with the receptors or synapses with the receptors. So when I stimulate the skin, sensory neuron hai, so obviously sensations will be on the skin. So when I stimulate the skin, now the action potential arises in the first node of Ranvier, and then it jumps from node to node and goes towards the spinal cord. Have you got my point? Right? See, if you stimulate a sensory neuron, how can the action potential arise in the initial segment? Initial segment is near the cell body. It will now arise in the first node of Ranvier, which is next to the skin. Right? So this will be, so motor neuron hai, to initial segment hai, sensory neuron hai, to initial node of Ranvier hai. Alright. So this is as far as your site of generation of action potential is concerned. Like I said, initial segment in the case of motor neurons and first node of Ranvier in the case of sensory neurons. Right. After this, let's have a look at the next one, and the next is what are the different phases of the action potential. So let's see the phases of action potential. What are the phases of action potential? Phases of an action potential. Now here is a neuron at minus 70 millivolts resting membrane potential. यहाँ पर हमने दिया एक threshold stimulus. There is opening there is minus 70 millivolts. There is opening of voltage gated sodium channels. This takes the potential of the cell to minus 55 millivolts, and minus 55 millivolts is the firing level. Minus 55 millivolts is the firing level. Minus 55 firing level. Now it causes after it reaches firing level, the opening of sodium channels is by a positive feedback mechanism. It is by a positive feedback mechanism. What is positive feedback mechanism? Mane? Entry of sodium causes opening of more sodium channels. More sodium entry causes opening of more sodium channels. So this is what is responsible for our depolarization phase. Please see this again. I know you all are getting distracted by whatever you're writing. Ignore it. We'll try and finish. Let's try and concentrate on the job at hand, right? And that is the resting membrane potential. Like I said, is minus 70 millivolts. This is the threshold stimulus that we've given. There is opening of sodium channels, influx of sodium. The potential changes from minus 70. It reaches the firing level of minus 55 millivolts. After it reaches minus 55 millivolts, now the opening of sodium channels is by a positive feedback mechanism. What is positive feedback mechanism? Entry of sodium causes opening of more sodium channels, more sodium entry, opening of more sodium channels. And now the potential of this neuron goes right up to 0. And from here it goes up to plus 30 millivolts, right? And this is what is known as the overshoot. Overshoot. It shoots above 0. This is your overshoot. This has been asked as a DNB question this year. What is overshoot? Overshoot means when it goes beyond 0. And this entire phase is known as the depolarization phase, and this is because of a sodium influx, right? Sodium influx. This is responsible for the depolarization phase. Clear? Now this was depolarization. Now there is opening of voltage gated potassium channels, which is responsible for the second phase, and this is your repolarization phase. And this repolarization phase is because of a potassium efflux. Potassium efflux. Opening of voltage gated potassium channels, and so this is potassium efflux. This phase where the potential of the cell becomes more negative. This is 1 to 2 millivolts more negative than the resting membrane potential. The potential is minus 71 to minus 72 millivolts during this phase. This is known as the hyperpolarization phase. Hyperpolarization phase, right? And this one here is known as the after depolarization phase. After depolarization phase. This is your after hyperpolarization and after depolarization phase. So let's go over the phases once again. I said depolarization because of sodium influx, repolarization because of potassium efflux, and you have a third phase which is the after depolarization phase, and the last one is the hyperpolarization phase, right? Now to understand these differences, please understand number one, though this is occurring after repolarization, but the name is after depolarization, so there should not be any confusion. After depolarization, see why the nomenclature is like this. This is because it is based on the history of discovery of the different phases. मतलब पहले ये वाला phase discover हुआ तो उसका नाम depolarization phase, then this one, and they called it after depolarization. So it's just the sequence of discovery of the different phases. Otherwise, there's nothing more to it, right? Now let's see what are the before I take on the reasons for these two phases. Let's see what is the difference between voltage-gated sodium channels and voltage-gated potassium channels. Let's see the basic difference between them. Voltage-gated sodium channels and voltage-gated potassium channels. Now, we have voltage-gated sodium channels. Voltage-gated sodium channels, the basic difference between them, they're both voltage-gated, right? But the basic difference between them is sodium channel is a fast channel and this is a slow channel. Fast channel and this is a slow channel, right? Second important point between these two channels is voltage-gated sodium channel. Now, at what voltage does this voltage-gated sodium channel open? This voltage-gated sodium channel opens between a voltage range of -70 to +30 millivolts. Voltage-gated potassium channel also opens in the same voltage range, -70 to +30 millivolts, right? -70 to +30 millivolts. They both open in the same voltage range, -70 to +30 millivolts. Right? Now, but which is the channel which will open first? The fast channel. Have you understood? The voltage-gated sodium-potassium channel, which is a slow channel, though it opens in the same voltage range, this will open later. That is why we have a depolarization phase first, followed by a repolarization phase. Have you got my point? This is the basic, though both the channels are opening in the same voltage range, but pehle khulega voltage gated sodium channel and this will open later. This is your, because this is a slow channel, right? Now, another important point, and that is, see, the opening of these channels is voltage dependent. I told you the voltage range -70 to +30. But the closure of these channels is time dependent. Now, what do I mean by that? The closure of these channels is time dependent, Mane. The channel after opening will close after a fixed time period. Mane, if a channel has opened, it will close after 1,000th of a second and then it will remain open for 1,000th of a second and then close. Closure is not voltage dependent, it is time dependent. Clear? Mane kya? Voltage gated sodium channel is a fast channel. It is fast to open, fast to close. Voltage gated potassium channel is a slow channel. It is slow to open, and by the time the voltage gated potassium channel starts opening, sodium has already started closing. So that means now I have a depolarization, sodium influx, followed by a potassium efflux. Have you got this point? Right? Sodium channel is a fast channel, fast to open, fast to close. By the time potassium channel is a slow channel, slow to open. So by the time the potassium channel starts opening, sodium has already started closing. But देखिए, अगर sodium influx and potassium efflux occur simultaneously, gain of positive charge, loss of positive charge occur simultaneously, there will be no change in potential. But now you're seeing a change in potential because you have a sodium influx followed by a potassium efflux. Okay? Now, to understand the hyperpolarization phase is not difficult at all. See, what is this hyperpolarization phase due to now? Now, this is due to, please remember, closure is not voltage dependent. ऐसा नहीं है कि potassium channels reach, the voltage reaches -70 and the potassium channels close. Potassium channels are slow to open, slow to close. And till they remain open, there will be loss of potassium. So hyperpolarization, now it's very, very easy to understand what is this phase due to. This is due to a delayed closure. Delayed closure or a slow closure, delayed or a slow closure of the potassium channels. जब तक potassium channel open है, now there will be a loss of potassium. so that the potential of the cell becomes slightly more negative, -1 to -2 millivolts more negative than resting membrane potential, -71 to -72 millivolts. So we've understood what is the reason for depolarization, repolarization, hyperpolarization. Clear? Let us now see after depolarization. What is this after depolarization phase due to? Now, see, what happens is basically, as the potassium leaves the cell, see if this is the potassium channel here, right? This is the cell membrane, this is a potassium channel. Now, as the potassium leaves the cell, this potassium goes and stands around the mouth of the channel. Have you got it? It's like too many of us are leaving the room at the same time. Some of us stand near the mouth of the gate or mouth of the door. So that the potassium which is coming from inside to outside, there is now a slight decrease. There is a slight decrease in the rate of potassium efflux. And this is what is responsible for the after depolarization state, right? Slight decrease in the rate of potassium efflux. Instead of going straight down like this, it sort of becomes a slight curve as it approaches the resting membrane potential. Slight decrease in the rate of the potassium efflux, right? So this is your phases of the action potential. Depolarization, repolarization, after depolarization, and the hyperpolarization phases. Next, let's see what is the refractory period. Let's see what is the refractory period. Now, what is refractory period? Refractory period is the duration during which a cell does not respond to a second stimulus. Refractory period is the period during which a cell does not respond to a second stimulus, right? Now, this refractory period is divided into two. There is an absolute refractory period and there is a relative refractory period. Now, what is absolute refractory period? Absolute refractory period is when there is no question of a response. And this is, please write it and then I'll explain whatever your query is, Ludhiana, I'll just sort it out. So, absolute refractory period is from the firing level till the repolarization. From firing level till repolarization is 1/3 complete. This is your absolute refractory period. Absolute refractory period is absolute refractory period this is the refractory period. That means this is absolute refractory period. This is the duration during which there is no question of a response. You can increase the strength of stimulus, you will not get a response. This is absolute refractory. Relative refractory means, if I increase the strength of stimulus, I will get a response. That is relative refractory. So relative refractory is from repolarization 1/3 complete till the start of after depolarization phase. Till the start of after depolarization phase. Now let's see these phases on the action potential. This is depolarization, this is repolarization, and there. This is what an action potential looks like, approximately at least. Okay? Now, let's see. This is the after depolarization, this is the hyperpolarization phase, which I've already discussed it with you because of the slow closure of the potassium channels. Right? Now, from the firing level, if this is minus 70 millivolts, this was the firing level, minus 55 millivolts, right? Now, from the firing level, ये firing level है यहाँ पर. From the firing level till the repolarization is 1/3 complete. From the firing level till the repolarization is 1/3 complete, this is called the absolute refractory period. What is the absolute refractory period, Mane? इस दौरान, if I give a second stimulus, I will not get a response. Relative refractory period is from repolarization 1/3 complete till the start of after depolarization. I hope you can appreciate this. This is where the after depolarization starts. It's a slight curve in the action potential because of a decrease in the rate of potassium efflux. So from 1/3 repolarization till the start of after depolarization is the relative refractory period. Mane, during this time, if I increase the strength of stimulus, I can get a response. That is relative refractory, right? So I hope, Karamsat, you've understood where does the repolarization end and the after depolarization start. Okay? Now, question says, Ludhiana says, ma'am, how does the graph will look like in hyperpolar? Have you seen this graph in hyperpolarization? This is the hyperpolarization phase. It has gone now below the resting membrane potential. During this time, the potential is minus 71. So this is what it looks like. This is the resting membrane potential here. So in the hyperpolarization phase, this is your hyperpolarization phase where it has gone below the resting membrane potential. Right? Ludhiana, ungated potassium channels are the ones which are responsible for the cell membrane permeability at rest. Na? We discussed that already. Voltage gated potassium channels will be responsible for repolarization. See, remember I told you that the cell at rest, when I say the cell membrane at rest is permeable, how does it become permeable to an ion? Because there are presence of these ungated channels, which cause the cell membrane to become permeable to that ion at rest. Voltage gated channels will open only when there is change in voltage. ठीक है? तो ये हो गया आपका absolute and relative refractory period. Now try and answer this Ames question. This Ames question says that a neuron is least excitable. A neuron is least excitable during. Neuron is least excitable during. Depolarization, repolarization, after depolarization, and hyperpolarization phase. बोलिए A, B, C या D? A, isn't it? Depolarization के समय a neuron will be least excitable. Have you got this? Neuron is least excitable during depolarization because depolarization comes in the absolute refractory period. Hyperpolarization में excitability is reduced. Excitability is reduced, but the least excitability will be in the depolarization phase because this is in your absolute refractory period. Right? Now let's go back to what I was trying to do with you. Let's go back to what I was trying to do with you. This is, remember I told you in hyperkalemia. I told you hyperkalemia. So ठीक है ना, Allahabad, but ma'am, it is not at all excitable. So that is least excitability, na? Have you got my answer? Right? Answer is A, depolarization. Right? Least excitable. Yes, this is your impossible to excite the neuron in the depolarization phase, because that is your absolute refractory period, right? So this is your so depolarization. So now let's go back to what I told you a little while back. Remember, I said in hyperkalemia, there is a state of persistent depolarization. Yes, I said there is a persistent depolarization state, and remember I said persistent depolarization in fact reduces excitability. Can you put 2 and 2 together now? We just discussed that during depolarization, the membrane, the cell is least excitable, right? So that means if a cell is in persistent depolarization phase, what will happen to its excitability? Reduces. Now I hope we can put 2 and 2 together. Hypokalemia reduces excitability because of a hyperpolarization. Hyperkalemia reduces excitability because of a persistent depolarization. Okay? Gorakhpur, let me see if I have time, I'll tell you about it, right? The activation and the inactivation gates. Okay, so this is your phases of the action potential. Next, let's take on, what do we understand by accommodation? Now, the definition of accommodation is a slowly rising current. A slowly rising current fails to stimulate a nerve. A slowly rising current fails to stimulate a nerve, and this is because of the nerve accommodates. There is something known as accommodation. This is a slowly rise. What is accommodation? This is a slowly rising current fails to stimulate a nerve, and this is known as accommodation. So let's discuss this in a little more detail. Now what am I going to do now is, now there are different, to stimulate an excitable tissue. Excitable tissue दो ही है. कौन सा? Nerve and skeletal muscle, right? So to excite and to stimulate an excitable tissue, I will give an electric current, right? Now, why electric current? Why do I use an electric current as a stimulus in my experimental studies? Is because, please remember, electric current, you can very finely regulate the strength of current, you can regulate the duration of the current, and electric current is least damaging to biological tissues, because remember, biological tissues also, electrical activity that is due to movement of ions is very commonly seen, right? So I prefer giving an electric current because why? I can regulate, I can finely control the duration, the strength of the current, and like I said, it is least damaging. Okay? Now the first pattern of the current that I'm going to give is, I suddenly increase the strength of current. Remember, on the y-axis is the strength. I give it for some time. X-axis is duration. And I suddenly bring it back to zero. This is the stimulus that I've given to an excitable tissue, right? And this is called a square pulse. Please remember, on the y-axis, I have the strength of current, and x-axis, I have the time, right? This is called a square pulse. I suddenly increase the strength, give it for some time, and then bring it back to zero. Second, again, I suddenly increase the strength of current. I suddenly increase the strength of current. Yes. and I धीरे bring it back to 0. Yes, this is another way. Please remember, the maximum strength and the total duration in A and B is the same. Suddenly increase the strength and current, and slowly I bring it back to 0. This is known as a sawtooth pulse. Third pattern is I slowly increase the strength of current. Remember, maximum strength in A, B and C is the same, and the total duration is also the same. And I bring it back to 0. And my question, in fact, this was an AIMS question which was asked, which one is least likely to produce a response? Which one is least likely to produce a response? Bolo. So no doubt about this? Yes? C. Why will C not produce a response? This is because, like I said, a slowly rising current fails to stimulate a nerve, and this is because of not adaptation, Karam Sir, it is accommodation. Adaptation is something different. I will do it with you in CNS. Right? This is accommodation. Clear? And see, ionic basis is very easy to understand. Right? Very easy to understand. What has happened over here? Not only have the fast voltage gated sodium channels opened, but now there has been time for the slow potassium channels also to open. You have opening of sodium channels and opening of potassium channels. There is a sodium influx and a potassium efflux. So no change in potential. Remember, I told you, for a change in potential, you need either a sodium influx or a potassium efflux. Both happening at the same time, no change in potential. Opposite of summation, can we really make it black and white like that? Alabad, accommodation, opposite of summation. I don't think, you can't call it opposite of something. They're two distinct things, isn't it? Opposite of summation, nahi kahenge, but yes. Right? So this is your opening of voltage gated sodium and potassium. Now, the AIMS question had given a fourth pattern also. Let me see if you will change your answer. Fourth pattern was a curvy linear pattern of current which was given. Now, is your answer still going to be C, or are you going to change it to D? This was an AIMS question which was given. Right? Yeah, my answer will continue to remain C. Why not D? Because C, look at the rate of change. Look at the slope, at least the initial slope of this. This is your, look at this. This is the slope here. So which one is least slowly rising? This is a least slowly rising current, and this one will fail to produce a response. This is least slowly rising. Whereas here, if you can, at least initially you can see the rate of rise is much more than that for C. So my answer continues to remain as C. Right? Chali. Least rising na? देखो ना, rate of rise कैसे होता है? ये slope gives you the rate of rise. So this is the least slowly rise. Look at the slope here and look at the slope here. See, Karam sir, the third one is also a sawtooth pulse. It is also a sawtooth pulse. But really, it is also a sawtooth pulse, but the direction of the saw is different, isn't it? Right? What is the reasons for accommodation? Ka reasons Mumbai? Phir se dekho. I just told you na that there is now opening of fast voltage gated sodium channels. So before the potential reaches the threshold, that now you have time for the slow potassium channels to also open up. Right? So you have sodium influx plus a potassium efflux occurring at the same time. So there is going to be no change in potential. Have you understood my point? Right? So this is your, I hope Mumbai, are you clear with that? There is opening of voltage gated sodium channels and the voltage gated potassium channels. Kya? Kya bol rahe Gorakhpur? What? Most slowly rising? Yeah, okay. So most slowly rising is least slowly rising. Okay. Or most slowly rising. Okay, fine. Most slowly rising is option C. So that is your answer. Okay, chalo, ye ho gaya aapka accommodation. Let's go on to the next one. Next is strength duration curve. Now, what is the strength duration curve? Strength duration curve is for the strength duration curve, what have we done? We have taken strength of current on the y-axis, strength of stimulus, and stimulus, like I told you, stimulus we use electric current. Stimulus is taken on the y-axis, and the time taken for response. अच्छा, बिलासपुर ये देख लो, फिर से देख लो. I said there are 4 types of pattern of current. Which one is least likely to produce a response? We decided that the least likely to produce a response is C. Why C? Because this is the least slowly rising or the most slowly rising, right? ये देखिएगा, the rise rate of rise is very slow here. Right? Why? What is, and this is known as accommodation. We've discussed already what is accommodation. A slowly rising current fails to stimulate a nerve, and this is known as accommodation. Right? This is your most slowly rising current is this one. So this one is least likely to produce a response. Right? And why does it not produce a response? Is because it has not only opened the fast sodium channels, but it has also opened the slow potassium channels. So there is a sodium influx and a potassium efflux, both occurring at the same time. So there is no change in potential. That is the reason why you do not see a response over here. Right? The fourth option is a curvilinear current. Again, if you look at the slope over here, slope here is higher than this one. So this one, the rate of rise will be more for this one as at least the initial rate of rise is more for this one as compared to C. So my answer continues to be C. C is least likely to produce a response. So Bilaspur, I hope you've understood it, right? Let's go on to the next. That was strength duration curve. Now we take strength of the electric current on the y-axis and the time taken for response. Time taken for response is on the x-axis. Okay. Now it makes a lot of sense कि अगर strength of current is more, time taken for response will be less. And if the strength of current is less, the time taken for response will be more. Right? And so that means I will get a response something like this. The graph that I will get will be something like this. More the strength of current, less is the time taken. Less the strength of current, more is the time taken. Right? More the strength of current, less is the time taken. Less the strength of current, more is the time taken for response. Yes, this is my strength duration curve. Now there are 2 or 3 definitions which I must do over here. And which are these 2 or 3 definitions? The first one is, what do we understand by Rho base? Now Rho base, let's write down the definition. Rho base is the minimum strength of current. Rho base is the minimum strength of current which when applied, Rho base is the minimum strength of current which when applied minimum strength of current which when applied for a prolonged period of time. Minimum strength of current which when applied for a prolonged, and in brackets, not defined. Prolonged period or a not defined period of time is known as Rho base. minimum strength of current which when applied for a prolonged period of time or a not defined period of time is known as Rho base, right? And the next one is utilization time. Utilization time. What is the utilization time? Utilization time is the time taken by a Rho base current to produce a response. Time taken by a Rho base current to produce a response is known as a utilization time. Rho base was the minimum strength of current which when applied for a prolonged period, prolonged or in brackets like I said, not defined. Not defined money. It can be milliseconds, it can be seconds, it can be minutes. Right? So Rho base is the minimum strength of current which when applied for a prolonged period of time produces a response. What is the complete definition, Karam said? Okay. So Rho base is the minimum strength of current which when applied for a prolonged period of time produces a response is known as the Rho base, minimum strength. That means you can apply this minimum strength of current for either milliseconds, seconds or minutes. It is not defined. It is not defined. So it's a prolonged period of time. Next is what is utilization time? Utilization time has been asked as a question in AIMS. It says utilization time is the time taken by a Rho base current to produce a response. Time taken by a Rho base current to produce a response. Then the third definition is chronaxy. Again, chrona is time. So what is chronaxy? Chronaxy is the time taken by a current which is twice the Rho base. Time taken by a current which is twice the Rho base to produce a response is known as time taken by a current which is twice the Rho base. It is known as chronaxy. Chronaxy. Right? Gorakhpur, please understand, accommodation is for a sub-threshold stimulus. Stimulus has not reached threshold. Right? Whereas when you talk in terms of strength duration curve, here the stimulus is when I say minimum strength of current, that means it is now reaching, it is producing a response. That means this is a threshold current that I'm talking about. So you cannot compare the two, right? Accommodation has to be a sub-threshold stimulus. Is it clear? So there is not even, what does it mean? It is basically, there is not even a local potential that you see there. Have you understood? That is what I mean by, that is what is meant by accommodation. Now this is a chronaxy is the time taken by a current which is twice the Rho base. Time taken by a current which is twice the Rho base is known as chronaxy. Now what is the significance of, so this was twice the Rho base here and the time taken is known as chronaxy. Right? Now what is the significance of chronaxy? Significance of chronaxy is lesser the chronaxy, more excitable the tissue. Lesser the chronaxy, more excitable the tissue. Right? Lesser the chronaxy, more excitable the tissue. Mane, please understand again, when I'm talking in terms of excitability here, I do not refer to the resting membrane potential. It refers to the time taken for response. We are defining excitability in the strength duration curve on the basis of time taken for response. So lesser the chronaxy, more excitable the tissue. If it's taking lesser time for response, obviously it is more excitable. In other words, which one will have a lesser chronaxy? Nerve or a skeletal muscle? Which one will have a lesser chronaxy? Let's have an answer. Nerve, obviously, isn't it? Because this is obviously the lesser it is more excitable than the skeletal muscle. Okay. Chronaxy of nerve is less than the skeletal muscle. Okay? Okay. This is as far as your. Also, please remember, chronaxy of, now you know we classify nerve fibers on the basis of the diameter. A is largest diameter, B is smaller, and C is the smallest diameter. So see this, chronaxy of type A fiber is less than chronaxy of B, which is less than chronaxy of C. Now it makes a lot of sense again because see, A is the largest diameter, and largest diameter means it has the maximum surface area. When it has the maximum surface area, that means it has the maximum number of sodium channels, and maximum number of sodium channels on the surface means it takes the least time for response. So chronaxy of type A is less than chronaxy of B, which is less than chronaxy of C. In muscles, right? Chronaxy of skeletal muscle is less than chronaxy of cardiac muscle, which is less than chronaxy of smooth muscle. Again, please remember, it is based on the time taken for response. Smooth muscle takes the maximum time for response because it has the least number of cation channels on the surface, right? So whichever tissue has more channels will take the lesser time for response, right? Now, what is the significance of the strength duration curve? See, strength duration curve, we do it whenever we are trying to monitor regeneration of a cut nerve. For example, after a nerve injury, when the nerve has got cut, what will happen to chronaxy? Chronaxy increases. But as the nerve starts regenerating, now the chronaxy starts decreasing. So that gives us an indication that yes, there is regeneration taking place. Lesser the chronaxy, more excitable the tissue. Regeneration would give us an indication that the decrease in chronaxy would give us an indication that regeneration is taking place. This is as far as your chronaxy, strength duration curve is concerned. Let's see the next one. Next, let's see. ये क्या हो गया? ये देख हिल नहीं रहा, कर्सर नहीं हिल रहा. Okay. Next, let's see what are the factors affecting velocity of conduction. What are the factors affecting velocity of conduction? Let's see that. Factors affecting velocity of conduction of a nerve impulse. Factors affecting velocity of conduction of a nerve impulse. The first factor, of course, is diameter, right? More the diameter, more the surface area, more the number of sodium channels. So what will happen to the velocity of conduction? Increases, right? There is increase in velocity. शिमला क्या कह रहा है? देख क्या लिखा है? शिमला वालों ने क्या लिखा है? ये शिमला ने क्या लिखा है? ब्रेक प्लीज. ब्रेक प्लीज मतलब? ब्रेक. अभी ब्रेक क्या? अभी तो 8:30 तो हो गए, 9 बजे तक तो क्लास है. चलो, anyway. So diameter, more the diameter, more the surface area, more the number of sodium channels, therefore faster velocity. Faster velocity, right? This is the effect of diameter. Now let's see diameter. So it makes a lot of sense now. More the diameter, more the surface area, more will be the number of sodium channels and faster will be the velocity. More the number of sodium channels means faster conduction, right? Now diameter can also be explained on the basis of axoplasmic resistance. Now what is axoplasmic resistance? Let's say this is one large diameter nerve fiber. This is large diameter nerve fiber, right? Now let's see, this large diameter nerve fiber is made of smaller diameter nerve fibers in parallel with each other. Let's consider that this large diameter, this large diameter nerve fiber is made of, let me just finish this and then we'll leave. All right, then we'll chhod do, just stop it. This is really dating a little too much. Just listen to this last bit and then we will let us just finish this first. Please leave, ma'am. और भी मतलब देखो तो सही, the guts, है ना? चलो. Okay. All right. This is a large diameter nerve fiber. Let's consider it is made of smaller diameter nerve fibers in parallel with each other, right? And whenever you have something in parallel with each other, this is, look at the resistance. What is the resistance of something in parallel with each other? This is 1 upon R1 plus 1 upon R2 plus 1 upon R3, right? Whenever you have something, whenever you have something in parallel, the resistance, please concentrate. This is an important concept and you all are distracting me and getting distracted yourself. Just sit patiently for 5-10 minutes. It's an important concept to understand. And because, why am I paying attention to this? Is because this is giving all ulta pulta in your guidebooks, and then you'll end up with problems and you won't be able to understand. So just spend 5 minutes, concentrate on this a little bit. And this is a very interesting concept as well. Difficult to understand and interesting. So let's not get distracted. Okay? We have a goal in front of us and we need to see, the easier thing for me is go fast, not bother about whether you have understood or not, and finish the class early. But then that's not what we are here for, isn't it? We have a goal, and that goal is your exam. So let's just concentrate and let's just see this. Just give me another 10 minutes and let's try and understand this, right? Okay. So now this is your, like I said, consider that a large diameter nerve fiber is made of smaller diameter nerve fibers in parallel with each other. And whenever you have something in parallel, the resistance becomes 1 upon R1 plus 1 upon R2 plus 1 upon R3. That means the resistance decreases. In other words, I can say that a large diameter nerve fiber has a low axoplasmic resistance. And when you have a low axoplasmic resistance, what will happen? If the resistance is less, what will happen to the velocity of conduction? Increases. So there is a increased velocity of conduction. Have you got this? Now this is, see, I've explained diameter on the basis of two things. Number one, we said more the diameter, more the surface area, more the number of sodium channels, faster velocity. Second, I told you a large diameter nerve fiber has a lower axoplasmic resistance, therefore a faster velocity of conduction. In other words, I can ask you this question another way. I can ask you that a large diameter nerve fiber has dash RA, low RA or a high RA. RA is axoplasmic resistance. A large diameter has a low RA, therefore a faster velocity of conduction. Is it clear? Right? So I've explained it to you on the basis of two things. How does diameter affect the velocity of conduction? Okay? Now the second factor which affects the velocity of conduction is myelin. And myelin, we know that in the peripheral nervous system this is produced by the Schwann cell, and in the central nervous system it is produced by the oligodendrocytes. So myelin is produced by the Schwann cell in the peripheral nervous system and by the oligodendrocytes in the central nervous system. Okay? Now when I look at myelin, see, myelin is an insulator. And what does myelin do? Myelin in fact increases the membrane resistance. It increases the membrane resistance, isn't it? It's like an insulator. So अगर resistance बढ़ता है, then in fact the velocity of conduction has to be low. More the resistance, lesser will be the velocity of conduction. So in other words, if myelinated nerve fiber, the resistance is more, velocity should be less. But of course, you know that in a myelinated nerve fiber, the velocity of conduction is faster. So let's see how. What has happened here? There are areas in a myelinated nerve fiber which has got no myelin, and that is the nodes of Ranvier. So what happens to the membrane resistance in these areas? The membrane resistance decreases. And if the membrane resistance decreases, at these areas is a very low membrane resistance. Now see, everything takes the path of least resistance. That's what we also do, isn't it? We also take whatever is the least resistance path, we go towards that. And that's exactly what your action potential does. Action potential goes from one area of low resistance to another area of low resistance to another area of low resistance. So it jumps from node to node. And when it jumps from node to node, what do I get? This type of conduction is known as, of course, the saltatory conduction. Right? So let's see this point in another way to reinforce this topic. Let's see this. When I talk in terms of a large diameter myelinated nerve fiber, large diameter myelinated nerve fiber has dash RA dash RM. बोलो, लार्ज डायमीटर नर्व फाइबर है तो एक्सोप्लाज्मिक रेजिस्टेंस बोलिए लो हो जाएगा. माइलिनेटेड नर्व फाइबर है तो उसका मेम्ब्रेन रेजिस्टेंस हाई हो जाएगा. सो लो RA, high RM. Right? In other words, when do I get the fastest velocity of conduction? Fastest velocity of conduction is seen when the ratio of RM over RA is high or the ratio of RM over RA is low. Bolo, A या B? A, isn't it? More the RM means it is a myelinated nerve fiber, right? Lesser the RA means it is a large diameter nerve fiber, and if the RM over RA ratio is high, means it's a faster velocity of conduction. Then somebody asked me, now when I said a myelinated nerve fiber has a high RM, but in spite of that, a higher velocity of conduction. Now somebody said, unmyelinated nerve fiber will have a low RM. Low RM, right? In spite of that, it has a slower velocity of conduction. Why? Because what has happened in the case of an unmyelinated nerve fiber? Unmyelinated nerve fiber, the action potential has to travel along the entire length of the axon. Right? But in this case, in the case of a myelinated nerve fiber, the action potential is jumping from node to node. Right? It is jumping from node to node. Vishakhapatnam, what do I mean by action potential jumping from node to node? What does this mean actually? See, the ionic changes, sodium influx, potassium efflux is only occurring at the nodes of Ranvier. Have you understood? So that is what is meant by jumping from node to node. Yes? Otherwise, this action potential has to move along the entire, in an unmyelinated nerve fiber, it will move along the entire length of the axon, and that will in fact decrease the velocity of conduction. Now, so like we said, large diameter myelinated nerve fiber has a low RA and a high RM. Now, a third factor which affects velocity is membrane capacitance. Now let's try and understand membrane capacitance without going too much of detail, without going into the details of physics, because that will just bog us down, right? Now please remember, we've done a capacitance in class 11-12 in our chapter on electricity. Now what is capacitance? Now when I look at a cell membrane has a high capacitance. Cell membrane by itself has a fairly high capacitance, right? Cell membrane has a fairly high capacitance. You know, its ability to act like a parallel plate capacitor is very high. It is myelin which reduces capacitance. Myelin which reduces capacitance, right? So in other words, if I ask you this question again now, a large diameter myelinated nerve fiber has dash RA, dash RM, dash capacitance. बोलिए, this becomes now low RA, high RM and a low capacitance. Please understand, a nerve fiber, a large diameter myelinated nerve fiber will have a low RA, high RM, low capacitance, right? I can ask you the same question again. I can ask you that maximum or highest velocity of conduction. Highest velocity will be seen in a nerve fiber with dash RA, dash RM, dash capacitance. Same thing. Low RA, high RM, low capacitance. Mane, I will see maximum velocity of conduction in a myelinated, large diameter myelinated nerve fiber. So low RA, high RM, low capacitance, right? Now tell me what is happening at the nodes. At the nodes, what happens to RM and what happens to capacitance? Bolo. Nodes per, what is happening to capacitance, what is happening to membrane resistance at the nodes of Ranvier? Silence? Okay. Meerut, thank you. So you have a low RM and a high capacitance. Agree with me? Right? Okay. Therefore, now listen to this question very, very carefully. Right? Very, very carefully. And that is, electrical properties. Electrical properties which favor conduction are dash RM, dash capacitance. Please understand, I'm not asking you about the node, about the nerves. Electrical property of nerve fiber. I'm just asking you electrical properties which favor conduction. Bolo. Low RM, good, low RM and a high capacitance, right? Oh, Dehradun. Capacitance, now I'm just talking about the electrical properties. Yes? See, look at these 4 or 5 questions which I've done with you, because this is all given muddled up in your, it's all muddled up in your guidebooks. So I want to spend a little time on this. When I said large diameter myelinated, remember this please, that myelin will increase the membrane resistance, decrease the capacitance. Okay? Cell membrane by itself has a very high capacitance, fairly high capacitance, right? So a large diameter myelinated nerve fiber has a low RA because of large diameter, high RM because of myelin, and a low capacitance, again because of myelin. Myelin decreases membrane capacitance. Next question I asked you, highest velocity will be seen in a nerve fiber with. So your answer becomes the same, low RA, high RM, low capacitance. Myelinated, large diameter myelinated nerve fiber. Next I asked you what happens at the nodes of Ranvier. This is a low RM, there is no myelin, so low RM and a high capacitance, isn't it? But so therefore my last question was, what are the electrical properties which favor conduction? Electrical properties which favor conduction are low R, just saying electrical properties, low RM and a high capacitance, right? Low RM and a high capacitance. This will favor electrical properties. Like I told you, cell membrane by itself is a good capacitor. Good capacitor. It's got a fairly high capacitance. So this is what is going to help in favoring conduction. Who told you, Ludhiana, that if capacitance increases, the velocity of decreases? It isn't that simple, right? It isn't that simple. And if you could, we could discuss this. And there is what is favoring conduction? Favoring conduction is what you see at the nodes of Ranvier. The cell membrane by itself has a high capacitance. It's the addition of myelin which reduces the membrane capacitance. Please, Ludhiana, please do not have this wrong notion that if capacitance increases, the velocity decreases. No, it is not as simple as that. Okay? So this is important point to remember. Cell membranes have a high capacitance. Addition of myelin decreases the membrane capacitance. Right? So this is as far as your velocity, that is axoplasmic diameter, membrane resistance, and last question, Bilaspur, see this. Electrical properties which favor conduction are. See, what are the properties which are helping in conduction is what you find at the nodes of Ranvier. Nodes of Ranvier में membrane resistance कम है, capacitance ज़्यादा है. क्योंकि ध्यान दीजिएगा, cell membrane का अपना capacitance high है, myelin की addition की वजह से capacitance कम हुआ. So therefore, my last question was simply electrical properties of a biological tissue. Please understand, I'm not talking about wires, electricity. That is not the one what I'm talking about. For biological tissues, biological tissues have cell membranes have a high capacitance. So electrical properties which favor conduction are low membrane resistance and high capacitance. Mumbai, again, you've got yourself into, you're tying yourself up in knots over this. See, again, though of course, yes, the myelin. Now let's see this. Mumbai, let me just try and sort out your problem. Oh. See, myelinated nerve fiber. This is an unmyelinated nerve fiber. Mumbai, yes, you're right. It has a low membrane resistance and high capacitance. So it should, what has happened here? Now the action potential has to travel along the entire length of the axon. Whereas in the case of a myelinated nerve fiber, the action potential is jumping from node to node. So which one is faster? जब आप चल के जाते हो या जब आप jump करते करते जाते हो? Have you understood my point, Mumbai? You're right. Unmyelinated nerve fiber has a low RM and a high capacitance. But what will happen here? Here it is traveling along the entire length of the axon. Here it is jumping from node to node. In spite of the fact that a myelinated nerve fiber, that's exactly what I'm trying to tell you. That in spite of the fact that this myelinated nerve fiber has a high membrane resistance, low capacitance, but it still has a faster velocity of conduction. I hope you've understood that, Mumbai. What are the others? What are the others saying? Oh, the difference, Dibrugarh, the distance between two nodes is 1 micrometer, 1 micron. Have you got it? क्या fly करके? Okay. Which one affects more? Myelin, diameter, capacitance to velocity? Myelination. Yeah. But see, myelinated nerve fiber, yeah, that is also another point which is going to favor conduction. Myelinated nerve fibers are usually larger diameter fibers. So usually they are larger diameter fibers. It is the smaller diameter fibers which are unmyelinated. So this will be another factor which will be favoring conduction. So yes, Aligarh, you're right. Okay, chalo, we wind up here, and tomorrow morning you have a class at 9 o'clock. So we'll continue from there. Okay, okay, good. अरे हल्द्वानी क्या बोल रहे हो एक बार? If velocity is less, then how electrical properties favor it? हल्द्वानी थोड़ा सा सोचो. Properties are favoring it. Yes, it is good, but it has to travel along the entire length of the axon, isn't it? But in a myelinated nerve fiber, it is jumping from node to node. Have you understood my point? So this becomes a faster velocity because of the fact it's jumping. That's all. So that is why I said make a distinction. Nerve fiber with which electrical properties, and electrical properties which favor conduction. My name is, I'm Dr. Anupama Chaudhary Devgan, right? Okay, and what topics are we going to repeat? What topics are we going to repeat? What topics are we going to do tomorrow? We will finish with skeletal. We'll finish with nerve. We'll do skeletal muscle. We'll take on respiratory system and probably kidney. Let's see how fast we go. Right? Okay, fine. Thank you.